This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es del Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
Good afternoon, everyone. We're going to go ahead and get started. Let me first introduce myself. I'm State Senator Ed Hernandez, representing the 22nd Senate District. This is the Senate Committee on Health. Today is the 19th of January, 2017. I believe I just saw one of our other members that just is going to be joining us. We're going to be holding an informational hearing on the Affordable Care Act in California, what's at stake, here in Kern County Administrative Center, first floor, obviously in the boardroom. I'd like to make a couple of opening statements, then I'll open it up to any of the members who would like to make any comments. But what I'd first like to do is just say I've been here for a couple days. I came here earlier, and I would like to say that I've been overwhelmed by the welcome and the kindness that this community has shown me since I've been here. I've learned a lot about the challenges that the residents of the southern Joaquin Valley are facing. And I'm looking forward to the testimony because I know I have more to learn. I know of all the members who have traveled here today are anxious to hear from the residents of Bakersfield and the surrounding communities, and hearing firsthand stories of how the Affordable Care Act has changed their lives. So I won't take too much time, but I want to acknowledge that there are a few regions in the country, or in the county, that have had more gaps in its healthcare system, for example, like the counties of Madera, Fresno, Tulare, Kings, and Kern in the years before the implementation of the Affordable Care Act. 20 million Americans, 5 million Californians now count on the Affordable Care Act to treat their pre-existing medical conditions and to provide health safety net for their children until they finish college and find a decent job that might provide medical insurance. For those of you who don't know, I'm a practicing optometrist, and I can tell you I've seen firsthand the benefit that numerous of my patients have had who've come in who've never had access to health care ever in their life. And the first time that they've come into the medical system where they've been able to actually see somebody and get care, and I've been able to witness that not only in the state senate, but also as a practicing optometrist. We're going to be starting off with some testimony today. I have a couple of announcements I'd like to make before we ask if anybody would like to make any comments for that are members. We do have Spanish language interpreter headsets which are available at the back of the room, which is provided by the Dolores Huerta Foundation. We will be having public comment at the end, but I'd like to just emphasize that I will not be having the counter on, the timer, but I'd like to ask everybody if they can try to stay under 2 minutes. They can be brief, succinct, and we are here to learn, but to allow everyone the opportunity to speak and have any concerns or any opinions. But also, I'd like to take this opportunity to thank an individual, the supervisor here in this area, Leticia Perez, who has allowed us to have this hearing in this facility. I believe she's here. Where is she? Oh, there she is. I'd like to allow her to come up and just say a few words, maybe some opening remarks. And again, I'd like to let my colleagues know that I'm very thankful and grateful that she allows us to be here in this facility. Supervisor.
Thank you. Thank you very much, Mr. Chairman. Thank you for giving the wonderful people of Kern County the opportunity to tell your committee about the impact the Affordable Care Act has had on our lives. Nearly half the 880,000 people living in Kern County have incomes that qualify them for Medi-Cal benefits. Thousands more who do not qualify for Medi-Cal also could not afford health insurance before the Affordable Care Act was implemented in California. Most of these people came to Kern Medical Center, the county-operated hospital that is now Kern Medical, for health care. For years, Kern Medical Center struggled with budget deficits and unstable finances. But today, with new leadership and an independent governing board, Kern Medical is operating in the black while meeting its core mission of serving those who cannot find health care elsewhere. I can personally testify to the quality of care at Kern Medical because last year, our son Noah was born at Kern Medical. Everyone who took care of us there, including the nurses in the NICU unit who cared for Noah for 6 weeks, was absolutely top-notch. Mr. Chairman, Kern Medical's new independence and its ability to compete in the healthcare marketplace could not have happened without your support for the legislation to create the hospital authority. So I thank you, and I thank the members of the Senate Health Committee. I still remember, Senator, leaving these chambers, getting on an Amtrak, and arriving in Sacramento at midnight to meet you at 8 a.m. at Starbucks across the street from the Capitol. You were straight with me, you were supportive, and you pushed this through and made it possible for Kern County. And to this committee and to you, I say thank you from the bottom of my heart.
And it's my pleasure, except you had me get up way too early.
But we can't ignore the critical role ACA has played in Kern Medical Center's dramatic financial turnaround. Under ACA, California has expanded Medi-Cal eligibility and has created a health insurance exchange, which sharply reduced the number of uninsured people in Kern County and has created a stable funding source for our hospital. A hospital in my district, a hospital that all of my siblings, my mother and all of her siblings, as well as my husband and all of his siblings, were born at. According to our Human Services Department, there are 314,000 Medi-Cal enrollees in Kern County, 95,000 of whom became eligible under California's decision to expand benefits under ACA. Another 17,000 people in Kern County have bought insurance under Covered California, the state's health insurance exchange. If federal payments to states for expanded Medicaid and Covered California do not continue, these programs will be endangered. New enrollees and those with health insurance for the very first time will likely become uninsured, and most of these people will turn back to Kern Medical for uncompensated care. This would have a devastating impact on Kern Medical's bottom line. Before ACA was enacted, patients who could not pay for their care accounted for about 23% of Kern County's total charges. The hospital's cost to serve these patients reached nearly $47 million in the 2009-2010 fiscal year alone, $47 million. Since ACA was implemented, Kern County's indigent population has dropped from 23%, Kern Medical's indigent population has dropped from 23% to 8%. And the county's annual cost for unreimbursed care at Kern Medical is now down to $3.4 million from $47 million. If Kern Medical loses the stable funding source provided by the ACA, it will still have to serve those in need with or without payment. The county contracts with the hospital to fulfill our state mandate to serve the indigent, so these costs would climb quickly to pre-ACA levels. This $45+ million cost would be met chiefly by the county's general fund, which is still ultimately responsible for the hospital's financial welfare. Another positive impact of ACA is coverage for mental health services. Now our mental health service staff can work closely with medical staff to identify people with behavioral health conditions and provide counseling and treatment. This early attention can keep smaller problems from becoming more serious, and it diverts many unhealthy people from the criminal justice system. But again, if the mental health benefit is removed, the county will lose $15 million a year that we are using to reach and treat many more vulnerable persons who desperately need our help. The county has a 150-year record of providing a safety net to those who cannot afford to pay for health care that would be in danger if we do not make the right decisions. As Congress considers how to replace the Affordable Care Act, I urge Governor Brown and the legislature to please work with Congress and the incoming administration to preserve federal support for Kern County's most vulnerable populations. Thank you for your time.
Thank you, Madam Supervisor. And does it feel a little awkward being on that side as opposed to being up here? Thank you for allowing us to be here. I'd like to see if any of my colleagues from the Senate Health Committee, of course, Assemblymember Arambula, have any opening remarks or comments. Yeah, we'll start off with Senator Mitchell.
Appreciate that. Thank you very much, Mr. Chair. Good afternoon. Hello to my colleagues. I just want to give brief remarks. I'm the chair this year of the Senate Budget Committee, and so while I'm pleased to serve on the Senate Health Committee, I also bring another lens to today's conversation in recognizing the value, the incredible value the Affordable Care Act has brought to California, not only for the obvious, all that we heard from the supervisor in terms of providing critically needed health services to California residents, which I certainly believe everyone is entitled to, but in my new capacity as budget chair, fundamentally understanding what it will do to the state's general fund if the Affordable Care Act goes away, what it will fundamentally do to job loss, the sheer economics of the healthcare industry in the state of California is massive. And so that's the lens I bring today, also recognizing that as policymakers who are responsible for delivering to you an on-time balanced budget, a budget that reflects the core values that all of us share as Californians, losing the incredible expanded resource of the Medicaid expansion dollars, and what that's done to our general fund and allowed us as policymakers to expand access to care has been critical for us as Californians. And so that's the added element that as all of you are tracking this conversation at the federal level, recognizing the job loss and the loss of critical resources to our state, what that could potentially mean. So that's the lens I'll also have on today, Dr. Hernandez, as we engage in this critical public policy discussion. Thank you for the opportunity, sir.
Thank you, Senator Mitchell. Senator Leyva.
Thank you, Mr. Chair. Good afternoon. Thank you, everyone, for taking your time to be here today. The Affordable Care Act has been so critically important for everyone up and down the state of California, but especially here in Kern County. Prior to running for the state Senate, I worked in the labor movement and spent 20 years fighting for health care for workers. When the ACA was passed, we became navigators at my local, and we signed up 500 people every single one of them said, I've never had health care before, which was shocking to me because I had grown up in a union household. I'd had a union job, so I'd always had access to health care. And I think it's just unconscionable that people who have taxpayer-funded health care, elected officials, would want to take away access to health care for other folks. So I am thrilled to be here today, thrilled to fight for health care for everyone. And just a little side note, I represent folks in the Inland Empire. If the ACA goes away, 277,000 of my constituents will no longer have access to affordable health care. Thank you for being here. Thank you, Mr. Chair.
Thank you, Senator Leyva. Senator Manning?
Thank you, Mr. Chair. Dr. Hernandez, I want to thank you and your staff for organizing this opportunity today in Kern County, and also want to extend my thanks to Supervisor Perez for hosting us along with the County of Kern and the Board of Supervisors today. And I want to thank all of you for being here today, recognizing the critical importance of the future of the Affordable Care Act and the future of health care in our communities. I'd also like to thank the Dolores Huerta Foundation for providing interpretation equipment, and beyond that for the work they've done supporting the underserved throughout Kern County and the state of California. It's actually Old Home Week for me. I spent a fair amount of time here in the 1970s in Bakersfield, Lamont, Arvin, Delano, Pixley, Visalia, Porterville, and feel a real kinship with the people of this region. We've heard for the last 5 or 6 years of the commitment to repeal the Affordable Care Act, or Obamacare. Repeal, repeal, repeal. And now the first votes have been taken to repeal. But we've still not seen any, not even a skeleton of the replacement. What will it look like? We've heard some bits and pieces. Oh no, we don't want to get rid of the pre-existing condition prohibition. We want to keep that, or we want to protect children up to age 26 if their parents have a plan. But we haven't seen a comprehensive plan. And as the supervisor laid out, and as my colleagues have laid out, the stakes are incredibly high. First and foremost, access for patients and families to health care, including prevention, including primary care that keeps people out of emergency rooms and keeps health care costs down, but more importantly, protects the public health. In this region, in the San Joaquin Valley, the documented public health challenges of childhood asthma, pesticide exposures, cancer clusters in the community of McFarland. We have a history of unique healthcare challenges in this region, and I would submit that the greater investment of federal public dollars in prevention, in diagnosis, in treatment, in vaccine campaigns, etc., has made our entire state a healthier state. But it's not just patients who are the beneficiaries. As was also suggested, doctors, nurses, technicians, other healthcare-related jobs, hospitals, clinics, community clinics that are eligible for a higher Medi-Cal reimbursement rate under Medi-Cal that allows the ability to provide quality care for patients, and certainly the impact on our state budget. Again, I look forward to hearing from you the concerns, possible recommendations and suggestions, and how we as the state of California raise a united voice to our local congressional representatives and make sure that they are a voice for the state of California. And I will just close by saying I'm incredibly troubled to hear the incoming administration talk about investing in broader nuclear arsenals and taking away from investment in our communities. I would submit that our national security is better protected by investment in our health care, our public health, and programs of prevention than wasteful dollars on expanded nuclear arsenals, of which we have sufficient capacity of deterrence and national defense. Thank you, Mr. Chair.
Thank you, Senator Manning. I wasn't sure it was Senator Newman, and I believe then we'll see if Assemblymember Rambula have any comments. Thank you, Mr. Chair. Turn it on.
Thank you, Mr. Chair. My name is Josh Newman. I represent the 29th Senate District. Like Senator Mitchell, I'm not only proud to be a member of this committee, I look through this through the lens. I'm the chair of the Veterans Affairs Committee for the State Senate. And many of our veterans, particularly their families, are dependent upon care provided to them by the Affordable Care Act. And we owe those men and women a great deal more than, in many cases, we've given them. And their children, particularly, do not typically receive veterans' benefits in the same manner that a veteran coming out. We're all familiar with the issues associated with the Veterans Administration, but what often goes unexamined is the degree to which young families coming home to a high-cost living state like California are dependent on public services, particularly the care provided by the ACA, and that is something we'll be looking at through my committee as well. Thank you.
Assemblymember Rambula.
So first off, thank you, Mr. Chair and members, for inviting me to participate. I'm happy to be back home. For those of you that don't know, I was actually born here in Kern County in Delano and moved to Fresno when I was 6. I've spent the last 10 years of my life practicing emergency medicine. And it was the problems in the ER that forced me to run for office. We were seeing 3 times the amount of patients last year than I did a decade ago. Yo no puedo ver a mi gente solo. I cannot see my people alone. And so I went to Sacramento to ask for help. Now I must admit I'm a bit troubled that the first time I get up there, that the first talk we're having is upending a system which currently is creating social injustice. Where I come from, in this valley, we have disadvantages. Now I'm a proud valley boy. This is my home, and I have set my roots here, and I will try to make this community better. But I feel like the federal administration is tying one hand behind our back if they're not allowing us to stand up and fight for our communities. Now here's what I struggle with. As an ER doctor, when they came to see me, I was mandated by the federal government by EMTALA, Emergency Medicine, Transportation, and Active Labor Act of 1976, which forced me to see everybody who walked through my doors. Now I'll tell you, it's an immense sense of pride that I took care of everybody, regardless of their party registration, regardless of their gender or ethnicity or who they prayed to at night. I took care of you because you asked for my help. Now I'll tell you what I believe, that healthcare is a human right, that when people need help, it's up to us to provide the infrastructure to make sure we're appropriately investing into our communities. Now, what I'm seeing is a social injustice where our communities are not allowed to live as long as other communities. That's a form of social Darwinism, where we've said those who cannot afford to pay for it are allowed to perish. And as someone who was on the front lines taking care of them, and it fell on my shoulders to bear these news, I must tell you that I instead decided to go make the government better. Because I was raised by a public servant who taught us that when you don't like the government you have, you go say something about it. You stand up. And as a Valley native, I'm proud to be able to stand up today and fight for our communities. Now I will tell you, just this past week or two, I got a chairmanship, which is new. I'm on the Assembly side, so my colleagues are on the Senate side, but I now chair the Budget Subcommittee on Health and Human Services. So from the Assembly side, the dollars that we spend in healthcare run through my committee. And I'm sure to have an opinion this year. But I'm going to share something if I may. Being a Valley native, I also have a congressional delegation which is currently in power in Washington, D.C. And I will look for opportunities to try to work with them towards Healthcare 2.0 rather than trying to take a step back. I'd rather actually figure out what's working with the ACA and figure out where we need to be going, because I think most of us can acknowledge that healthcare today is already too expensive, and too difficult for us to access. And so we must start working towards what Healthcare 2.0 looks like. I look forward to hearing from all of you, and I'm gracious that we're back here in a place that I love.
Thank you very much, members. We're going to go ahead and get started. Couple of updates. We have some individuals that may have to leave by 4 o'clock or 5 p.m. If we don't get to them, then I will move them out of order and move them up. But at this time, we're at item number 2. We're going to do the consumer experiences. If we can have those individuals come up to the various panels here, to, I believe, to my left. We have Julie Ortero, Medi-Cal consumer. We have Andrew Miskowitz, a Medi-Cal consumer, and Jimmy Cruz, a Covered California consumer. So I don't know who would like to go first. Let's go ahead and start with Julie if she's ready. And I think there's, turn your mic on. If you look at the, over there, the screen, look at the screen, there's it says mic on.
There you go.
There you go. There you go.
Okay, is it on now?
It's on now.
Okay.
Yes. Welcome.
Sorry,
and thank
I'm kind
you.
of sliding out of this chair. Hi, good afternoon, everybody. My name is Julie Otero. I wanted to thank Senator Hernandez for convening this hearing today and everybody that's here today. As I was sitting there, actually I had something written that I wanted to convey with you guys, but as I was sitting there, I was feeling more and more proud to sit there to hear you guys speak.
Yes.
Because everything that I've been feeling for the past few months that I've been advocating regarding this program, you just said it, all of you. One thing, but it all came together to what I feel and what I say. And I know I'm not alone anymore. And I wanted to thank you guys. Because I'm here today, I'm a United Domestic Workers for the Kern County District. I'm their representative. I represent about 2,500 workers in this country, in this county. I'm also a worker. I take care of my mother. She's 85 years old. I started advocating for the elderly and the sick every chance I could get. It's something that comes up. It's a passion I have. When the Affordable Care Act came to place, I was able to see the doctor. I haven't had a doctor for maybe a year and a half because our union, our job does not provide health care. So I was static. I was feeling sick all the time, and I didn't go to the hospital because I know I was going to get stuck with the bill that I couldn't afford. Unfortunately, that brought more problems later on for me because I had a condition I didn't know I had any progressed. I am suffering from 2 lung diseases, pulmonary hypertension, and severe COPD. Normally people associate these diseases with smoking. I had never in my life smoked. I had never in my life taken a drink, beer or anything, or any recreational drugs. And I'm suffering from 2 diseases that had no cure. Because of this program, it basically saved my life. I was told exactly January last year, as I was being hospitalized with severe pneumonia, that I didn't have much longer to live because of these diseases were grabbing me. At that point, the Affordable Care Act came into my life, and I was able to stay at the hospital, and I was able to take the care that I needed. If it wasn't for this program, I would not be here today, ladies and gentlemen. I'm a mother of 7. I raise my children, they're all adults now. I work every day, but I don't make enough to pay for my medicines. Last month, I went to my pharmacist and I wanted to know what because I got terrified when I heard that this program was going to be abolished. So I went to my pharmacist last month and asked to please give me a printout of all the medication that I take a month since January to this January. Where is over $4,000? That is more than what I make a month. I can't afford it. That's just the medication that I drink. That's not the oxygen use that I use 24 hours a day since January 5th, 2016. This is a 24-hour thing, and that wasn't counting that. I take care of my mother. She's 85 years old, on her last stages of renal failure. Because my own health right now, I'm able to manage it with the medication. In this program, I'm able to fulfill the promise I made my mother when she was well, that I would never put her in a home and I would stay by her side until God says otherwise. But without this program, I would not be good to her or anybody else if I don't have the health care. I'm not only here today for me, I'm here for the millions of people, all nationwide, all United States, and all the people in this county that suffer lung diseases. There's a lot of people in this county. Unfortunately, we don't have the best air in here, and I believe that's why I developed the lung diseases that I have today. They don't have the money to pay for their medication. Without this program, we're not only looking at job loss, we're looking at life loss. My life expectancy would be near none because I wouldn't be here. My children wouldn't have their mother. And I'm here because to me, I'm not looking at this as a politics thing. It's not about politics for me. It is about the loss of life that would occur if this program, with the glitches or whatever they say, doesn't work. It has saved millions of lives. Millions of lives. And this is what we are going to lose, is this program no longer will be available for us working people. We are not sitting at home. We are working people. I have produced. I pay my taxes, and I'm not able to afford. It is just the right of all Americans to have decent health care. We're not asking for much, but health sometimes is not something we choose. I didn't do this to myself. I'm not a smoker. I didn't choose to have this disease. I'm dealing with it as millions of you all over. I ask everybody, friends and family, please get involved. Everybody's voice, it is important. You think it's not going to touch you? It will touch one of you, people that you know, your friend, your family, your children. Sickness don't have no gender, no color, and no nationality. We need everybody as a unity to be together. We'll be strong. Thank you very much for giving us a platform to speak, because we need a voice and we all need to be united in order to move forward. I have been researching for months, and not yet I have seen something that will take this pain that I have in my chest, that if I don't have health care, I won't be around for my family. Everybody has a backup. Even the president has a backup. Why don't we have a backup for our health care? Why don't we have a backup for our lives, to save our lives? It isn't responsible to take this program away without having something better. Don't take it away, make it better. Fill the potholes. Have they fill the potholes in the street when there's a hole and you don't want your tire to be broken? Fix this program, make it better, but do not eliminate the one thing that we have to survive and to be productive human beings in these societies. Because we're not a leech. We are human beings, and we deserve better. Thank you very much.
Thank you very much for that testimony. We're going to move to the second presenter. It's Andrew Miskovich, a Medi-Cal consumer as well.
Yes.
Welcome.
Can you hear me okay?
Yes, we're good.
Okay.
Welcome.
Thank you, and thank you for this opportunity to speak. I want to give you a brief history of myself. Approximately 12 years ago, I became homeless. And after 6 months on the streets, I started trying to find a way off the street. Started reaching out to programs to see if they could help me get off the streets. And at that time, I didn't qualify for services. So I eventually stayed on the street another 4 years. And during that time, my undiagnosed mental illness worsened. And I qualified quickly for services through a county mental health system. And they gave me access to doctors and medication and helped me access my SSI benefits. And at that point, the funding dried up for this program, and so I was thrown I was set on my own to take care of this. And all I had was the county medical to take care of this. And my condition, depending on my access to doctors and inconsistent access to medication, my condition went up and down. And finally, when the Affordable Care Act came into being, I was able to access quality doctors and have access to my medication consistently. And I've improved so much that in the next couple of months, I'm going to start job training to go back and become a productive member of society. And it's scary to think that the rug could be pulled out from under me just coming up. And it also affects me in another way. My partner, 6 years ago, was diagnosed with HIV. And in the beginning, he didn't have access to quality medical care or medication. And he got to the point where he had less than 8 months to survive, and then he was able to get access through the Affordable Care Act, and he's now undetectable, and he's recently started working, and he's becoming a productive member of society. And if the Affordable Care Act is repealed and they take this away from us, within 2 weeks, I'll start losing my mental stability again. If my partner loses access to his medications, within 3 to 4 days, he becomes immune to these medications and his condition will start to worsen. And we're both flourishing right now. And if this Affordable Care Act is repealed, it's like pulling the rug out from under us, and I don't know what we're going to do, and it's scary. And I need your guys' help to express this. And thank you for listening.
Thank you very much, and I appreciate your story. We're going to move on. I believe Jimmy Cruz is over on this side. He's a California consumer, and after him, we're going to go out of order because we have an individual that has to leave by 4, but if you would please proceed. Thank you very much.
Well, I want to thank you all for this opportunity for me to speak. Yesterday, I was watching the news, and I was telling my partner if there was only a way that I would be able to speak how I feel about this. Watching the news and stuff, I just started crumbling inside. Because I also, too, I have type 2 diabetes. And my medication, I take up to 10 different types of medication. Without this Affordable Care Act, my medications would be $1,326.90. I only make a year before taxes $1,640. Okay, with this insurance that Obamacare has offered me, I'm only paying $118 out of that. And it's helping me out a lot. My mom passed away because of complications of diabetes, and so did my dad. And I'm sitting here and I'm thinking, if I get this taken away from me, am I gonna get an arm cut off, feet, go into a diabetic coma, lose my sight? I'm working right now. Do they want me to get on disability? Or would they rather me have this insurance to get my medication to be able to work? You know, I've never had insurance before. I'm one of those that Letty was talking about not being able to afford insurance. With Obamacare, I can't afford it right now. My monthly payments is $78.33. And I also have dental now, which I needed because I lost all my molars because of different reasons the past tense. And I only pay $10.50 a month. This has helped me out so much to be able to get up on my feet, go forward. My roommate is on disability. He's in a wheelchair, car accident. What do they want, 2 of us rolling around in a 1-bedroom apartment on chairs? If they amputate my legs? What am I going to do without this insurance? Am I going to be one of those people that are going to be, after a couple of years, maybe a year, maybe not even that long, go into a coma? My family losing me? I don't want to be that person. I want to be able to continue forward. With this insurance, it's helping me out a lot. You know, it's scary. I was terrified when they started talking about taking it away. What was I going to do? Oh, they're going to put something in its place? Am I going to be able to afford that? I'm affording it now. I'm able to live right now. I'm able to work. Because I don't know if anybody out there has diabetes, but diabetes can hit you in many ways. And that scares me. You know, I don't want to be like my mom. I want to live a long and prosperous life. I'll be 52 next month. And I don't think I would have made it this far if I didn't get the medications that I needed. Because I went semi-blind around 4 years ago before I was able to get this insurance through Obamacare. Now, I don't have that problem. My sugar was once up 500 and something. Now I keep it below 200. I don't worry about being amputated. I don't worry about going blind. I don't worry about falling into a coma. Now, where am I going to be if I can't afford this insurance? Because if I don't have this insurance, I sure cannot afford with what I make. I make $10.25 an hour to pay $1,326.90 a month for my medications and the things that I need because I have diabetes. Where am I going to be if Obamacare gets taken away? I'm scared. And I work with a lot of other people that have this insurance. I work in a convalescent hospital. We take care of elderly people. And I see a lot of them with amputated feet. I don't want to be one of them. I want to be able to live long and have every member of my body attached to me when I leave, like I came in, not have it amputated. And that's how Obamacare has helped me. And I really appreciate it. Thank you.
Thank you very much for that testimony. So let me just commend everyone who had the courage to come up here and speak, tell of their personal stories. Obviously, it was very, very difficult, but this is the reason why we are here. We are here to hear the stories and the effects of real people, and that's the message that we have to be able to give and the message that we have to fight for to make sure that we protect what we have here in this country, which is to be able to have the Affordable Care Act or access to health care. I was just notified that the speaker does not have to leave until 4, so we will not skip. We'll now go on to item number 3. We're going to do an overview of coverage expansions and market reforms. We have Deborah Kelch, Executive Director, Insure the Uninsured. So welcome, and please proceed. And again, I want to thank all those presenters for coming down.
Thank you. I have to go to the
Thank you.
Martin Luther King about the Obamacare too.
Thank you.
Thank you, Senator, Mr. Chairman and members. Deborah Kelch, Executive Director of Insure the Uninsured Project. Little difficult to follow the testimony we've all heard, really makes it very real. But thank you for bringing that to all of us. It keeps us going forward, I think, just to remember why we do what we do, whatever that role we play. So thank you. Excuse me. Did kind of catch me a little. So I am the executive director of Insure the Uninsured Project. ITUP is a nonpartisan, independent 501c3 organization. We were founded in 1996 when federal health reform failed, with the vision of our founder, Lucian Wilson, that California needed to come together at the state level and see what we could do if the solutions were not going to be coming from the federal government. So ITUP works to advance creative and workable policy solutions with the goal of expanding access and improving the health of Californians. My job here today is to talk a little bit, as the chairman said, about kind of what we saw in our experience before the Affordable Care Act in terms of coverage and markets, what California has done, so much that we have done. I would have had to talk a long time to really capture everything that we've done in these years, implementing not just the coverage expansions, but all of the extraordinary work everyone's doing around the state to improve quality, to improve access, to join in partnerships, reduce costs. And then I'll talk very briefly about what's at stake for California, but as you know, we still don't really know the answer to that. So where were we when we started? So we had for decades, and I had occasion to just do some research, and going back to the mid-1980s, our uninsured rate hovered at 20%, 18, 19, 22, but it was consistent. In 2013, there were 6.5 to 7 million uninsured Californians. Employer-sponsored coverage was declining. More employers were changing their offerings or stopping coverage. Individual coverage was not available to people with pre-existing conditions, and most low and moderate income Californians, even the healthy ones, really couldn't afford to buy individual policies. People who did have coverage often had low benefit, low value coverage, but were still paying very high premiums. Medi-Cal was only available to children, seniors, and some disabled, and some low-income parents. So that's where we were. We had 7.9 million people enrolled in Medi-Cal. Eligibility was based on income, but you also had to have another criteria to match your low income to be covered. So children and some parents, pregnant women, seniors, and qualifying persons with disability. Importantly, working adults, like the ones that you've heard from here today, without children were not eligible regardless of income. And we had a really complex enrollment system with limited application entry points and completely inadequate application assistance. Our individual market, as we talked about, you could be denied for pre-existing conditions, and I did a lot of work on the policies at that time, and it wasn't just the obvious things like cancer and HIV/AIDS or other life-threatening illnesses, but hay fever and whatever criteria, diseases, or conditions health insurers decided would make you uninsurable, totally at their discretion. Rates for people who did have health issues, if they could get coverage, were higher than for anyone else. California had a high-risk pool known as the Major Risk Medical Insurance Program. However, we struggled to fund it. It was plagued with waiting lists. It was expensive for people who bought it, and the coverage they had was unbelievably limited. So it was limited to $75,000 per year for people with the sickest and highest cost conditions. In our pre-ACA individual market, many policies had such limited benefits and inadequate coverage, there were no standards for that. People could experience annual and lifetime dollar limits, which I think sometimes is kind of a vague concept. What that means is if you got really sick, your coverage could just plain stop when you reached $1 million. So if you had a very high cost illness, you're done. Premium rates were not easily found. You had to apply multiple times to multiple carriers. You wouldn't know what your premiums would be, and there was almost no regulatory review of either premiums or rate increases. In California, we have 2 state regulators, and before the ACA, the benefits were really different. And there wasn't any way for consumers to really see and understand why that's so. Under the Department of Insurance, the coverage could be less rich. There were no benefit standards. Under the Department of Managed Healthcare, there were some standards, but even prescription drugs were not mandatory. It was just really hard for consumers to understand or to compare their coverage options. So California fully embraced the Affordable Care Act right away in 2010 after it passed. We enacted the first law in the country to create an ACA marketplace, and we added, as always we do, some California-specific enhancements and improvements. We passed and improved ACA insurance reforms in the individual and small employer market. We expanded Medi-Cal eligibility to the maximum allowed under the ACA, and last year we covered all low-income children regardless of immigration status. We invested in statewide marketing, outreach, enrollment assistance to make sure people could know what their options were and get enrolled. And we saw a dramatic reduction in the number of uninsured for the first time. We went from 7 million uninsured to 3 to 3.5 million uninsured, the largest reduction of the uninsured in any state. Overall, Medi-Cal enrollment increased dramatically, and the ACA coverage expansion added 3.9 million Californians to the rolls to make sure they had coverage. Covered California enrolled 1.4 million. Our current Medi-Cal program is projected to cover 14.3 million Californians in 2017-18. What we really have now is universal coverage for citizen and lawful resident Californians who are under 138% of the federal poverty level. It covers children and pregnant women at higher incomes. And like I said, to our credit in California, our program covers all low-income children, regardless of immigration status. Importantly, more than 1/3 of Californians, 60% of California children, are now covered by Medi-Cal. And we improved the eligibility and enrollment process. I think we would all say it could keep getting better, but we made a lot of improvements. We streamlined things. We made it possible to apply online. And importantly, we expanded coverage for mental health and substance use disorder treatment in the state. Our private insurance market, the employer market, has stabilized. So sometimes you hear employers are dropping coverage a lot around the Affordable Care Act. That's not proven to be true here in California in significant numbers. And all individual and small employer coverage guarantees, regardless of health status or pre-existing condition, children can stay on their parents' coverage. All those confusing and conflicting benefit standards have been standardized, and there are no more annual and lifetime limits. There are limits now on what consumers will have to pay out of their own pockets in cost-sharing, co-pays, and deductibles. And the benefits are standard. Everyone will have a minimum set of essential health benefits. It includes prescription drugs, prenatal care, and, as I said, I think significantly, mental health and SUD treatment. There's no cost sharing for preventive services. And I spoke just the other day with a researcher here in the state who said they're finding more people are being diagnosed with prediabetes because they're coming sooner. That's really dramatic and very important. Annual premium rate filings and rate review happens, and rates can only be based on age and geography, not health status. Covered California is a successful marketplace, one of the most successful in the country. Our exchange is an active purchaser, so that means for the first time, consumers have someone negotiating with the health plans on their behalf, versus in the previous situation where individuals were left on their own to try to find a decent price and good coverage. Covered California offers subsidies up to 400% federal poverty level. 90% of enrollees in Covered California receive some form of subsidy. Covered California also, under the state law, standardized the benefits, which is a huge leap forward for consumers to be able to see one to the next health plan offering the same benefits, that their price is different, and enable them to find the one that works best for them. They operate an online application eligibility portal. And like I said, California really went beyond the federal law to make sure our market and our marketplace would be viable, both inside and outside of Covered California. It's also important to remember that a lot of the ACA protections apply to large employer coverage. So some of the things that we're familiar with, it's not just the individual and small employer markets and Medi-Cal. So this means that people with job-based coverage in large employers also have no cost sharing for prevention, no annual and lifetime limits, a limit on their out-of-pocket costs, no waiting periods, and at least a minimum value standard of 60%. So the question, I guess, that you're beginning to try to grapple with is what's at stake? Well, given the progress we made, it seems clear that a lot is at stake for California. But what we know suggests the possibility that our coverage expansions could be at stake if federal funds for Medi-Cal and Cover California are reduced or eliminated. Once again, individuals could be denied coverage or charged higher rates, and we could be working to establish a new high-risk pool with all the challenges we faced before. And even when there's discussion of keeping the ability to, the prohibition on pre-existing conditions, then what we know is our insurance markets could be dramatically disrupted if the requirement for everyone to be in the insurance pool is also eliminated at the same time. Depending on federal action, many of our extraordinary implementing laws could be automatically repealed within 12 months or become unenforceable. So one thing we can look to as a potential of what we might see is legislation passed in 2015 by the Republican Congress and vetoed by President Obama. That budget reconciliation, which is the same process that is under consideration now, eliminated the ability of the federal government to operate exchanges, phased out the premium subsidies, eliminated the tax penalties for individuals' employers, eliminated the taxes and the revenue generated, medical devices, Cadillac tax, and others, and phased out the expansion of Medicaid over a 2-year period. So that's something we can see. It's not certain that it will look the same, but it gives us a flavor for some of the things we'll be discussing in the coming months. So what's next for California? We don't know, right? So, but we know there are multiple proposals and approaches emerging. ITUP believes, and I know you do too, that California can and should still lead the nation in expanding access and improving the health of Californians. And we just like to tell you that ITUP will be here with you, monitoring issues and events, and we hope to be a resource to you going forward. With that, I'd be happy to answer any questions that you might have.
Thank you very much. Are there any questions from any of the members? Senator Mitchell.
I just have to say, how you doing, Ms. Kelch?
Good, Senator, thank you.
Looking at that presentation, it's amazing how quickly I forgot about those days pre-ACA. And so that was a healthy, important reminder, particularly for some of our newer colleagues who may not have been working in health policy as I have most of my professional career. Ms. Kelch and I go back decades.
Yeah.
But for nothing else, as a policymaker now, I am so clear that we cannot go back. Mm-hmm. We just cannot. And as one of the earlier witnesses talked about, you know, how can, you know, then tweak it, fix it. But to suggest that a policy of that magnitude was somehow a failure, where the most populous state in the nation was able to cut our uninsured population in half, is a misnomer at best and a lie at worst. It worked for far too many for us to simply say that it's a failed policy. So thank you for that walk down memory lane, but to really critically remind us about how far we've come in a really short period of time in terms of the delivery and of expanding access to services to Californians who are entitled to it. It just struck me.
Thank you.
Thank you. Anyone else like to have any questions? Yes, Senator Mani.
Thank you, Mr. Chair. I also just want to add my thanks. It was a really well-framed presentation of past, present, and unknown future. One question you did illustrate, I think media has not, there's been a lot of focus on pre-existing conditions and coverage of children, of parents with a plan up to age 26, but not a lot of coverage of lifetime caps.
Right.
And could you just comment or just remind us what that means and what would be the impact, not just to patients, but to financing our medical coverage system?
Sure. So prior to the ACA, coverage could legally include two kinds of dollar limits, essentially. One is an annual limit that would say, so we're kind of all familiar with annual deductibles, but there was also this other sort of ticking time bomb if you were accessing health care through the year. And particularly, obviously, if you had a very severe illness and your costs were really high. So you might have $1 million or a $2 million annual cap, and that would come into play for people who, again, had even just maybe one serious accident could do that if you had to be in the hospital a long time. So that was the annual cap. In addition, policies could also limit the overall lifetime benefit. And this was primarily coverage under the old insurance code because it didn't require that all medically necessary services, so the benefits were more fixed, like you so much of a hospital and so much a physician. And then it could add to that a lifetime cap so that a person could be in a course of treatment, basically. Obviously, a very sick person who is going through maybe a $5 million or a $10 million and now is at that lifetime limit, and their coverage would be over. Just done.
Thank you for that clarification. And again, the medical insurance industry, which obviously liked that lifetime cap system, with the ACA and an expanded risk pool and more people paying in, we haven't heard them complaining about the elimination of the lifetime cap, although I'm sure they would like it to be restored.
Yeah, I'm not sure either, but I think if the one thing that the ACA did was, which was really helpful for everyone, so it phased those changes in. So we didn't start by eliminating annual caps the first year. We gradually worked our way through lower and lower caps until they were eliminated. And I do think that coincided with that, you know, kind of the gradual increase in coverage, as you suggest, with more people who are both healthy and in need of health services, so that eventually the annual and lifetime caps could be managed. No question, when you increase benefits and you limit the the way that they cap coverage, it does cost a little more in the premium, but we've matched that by bringing Covered California online and creating a more competitive market, and we've had good experience in California with not having our rates soar. So.
And I think, is it fair to say that if lifetime caps were restored, that somebody who's even in the course of treatment could get that letter from their health plan saying you've hit your lifetime limit, we're no longer paying any bills, and then that patient's going to look to the state, to emergency room treatment. Somebody's going to be asked to pay those bills. So it's not like the bill goes away, but it will lead to more bankruptcies and more tragedy of somebody not being able to have continuity of treatment. Is that a fair statement?
No, I think that is a fair statement. I also think a question would be where those limits are set, because if you kind of go back to the limits I've been talking about, which are back a few years, $1 million of health care, which seems like a lot, but again, you know, one really serious illness or one major accident or emergency, and you could be in that situation. And it's certainly the case that as soon as the coverage ends, the person is responsible for the remaining costs. But as you suggest, when people can't pay, then we fall back on a safety net. It's almost as Senator Mitchell was saying, we have to kind of remember how that goes, you know? So we are talking about our public health systems, we're talking about our hospitals, we're talking about our providers, our physicians in the emergency room, but otherwise who are not going to be able to get payment. And we were talking about individuals running up enormous costs and potentially having a financial ruin as a result. And bankruptcies were related to medical were very high in that, you know, it sounds like it was kind of ancient, but it wasn't really that long ago.
Thank you. Seeing no other questions, let me thank you, and let me reiterate what Senator Mitchell said. It was an excellent presentation, kind of laying out its implementation. I will say that I believe California has done an incredible job with embracing the Affordable Care Act. I think we have had some of the lowest rates in the country as far as premiums. And I think it's mainly due to the fact that Covered California is an active purchaser, which negotiates on behalf of the consumer. And again, finalizing what Senator Manning said, prior to this, we had the highest number, not only in the state, but within the country, of individuals going into bankruptcy because they had insurance policies they thought covered most of their conditions, were hit with a catastrophic illness and had to file for bankruptcy. There is a lot of good within this, and I'm not saying it's a perfect bill, but I think what we have to look at is how do we have that dialogue with this new administration and say, look, this is what's working in California, let's make it even better. But to just throw the baby out with the bathwater is not the answer, and we have to make sure that we retain what we have and make this even a better system. But anyway, let me just thank you for being here as well. Seeing no further questions, we're going to move on to the
Thank you so much for having me.
To the next panelist. We're at state programs. We have two individuals that will be speaking. We have Anastasia Dotson. She is the Associate Director, California Department of Healthcare Services. And we have Kelly Green, Director of External Affairs of Covered California. First of all, I'd like to welcome you and thank you for being here in the Central Valley in Bakersfield. And I believe we'll let Anastasia Dotson go first, and please proceed.
Thank you so much, Mr. Chair, and members of the committee. Pleased to be here today. My name is Anastasia Dotson. I'm the Associate Director at the California Department of Healthcare Services. We're the state department that manages the Medi-Cal program, and I'll be talking a little bit about our implementation of the Affordable Care Act and Medicaid expansion in California. The Department of Healthcare Services, we help ensure that Californians have access to quality healthcare services that are delivered effectively and efficiently. Our programs integrate all spectrums of care, primarily via Medi-Cal, which is California's Medicaid program, as you well know. Medi-Cal is a federal-state partnership that provides comprehensive health care to a wide range of individuals and families. Right now, we're directing service for approximately 14 million Californians. And again, as you know, and we've discussed, in January 2014, California implemented the major elements of the Affordable Care Act, including the Medicaid expansion, which extended eligibility to non-disabled adults without minor children and parent and caretaker relatives with incomes up to 138% of the federal poverty level. In 2017-18, which is the upcoming budget year, an estimated 4.1 million Californians will be enrolled in Medi-Cal as a result of that Medicaid expansion. And again, overall in Medi-Cal, we'll have about 14 million Californians. So as far as implementation of the Affordable Care Act, we, as you can imagine, the effort to implement the expansion, the Medicaid expansion, required a lot of planning and collaboration among many, many partners. So we had a state and federal partnership that was strong and robust, and we had a strong partnership with Covered California, with counties, health plans, hospitals, clinics, physicians, local CBOs, and consumers and consumer groups, many of the folks that are probably here today. It was a tremendous process to get many different pieces of the Affordable Care Act up and running, and it really put our state at the forefront of expanding health care across the nation. So some of the specific efforts that our department implemented, again, sometimes just for Medi-Cal and many in partnership with Covered California, expanding Medi-Cal, as I mentioned, also developing a single streamlined application and a joint online application portal with Covered California. The system is called CalHears, but to consumers, they see it as the Covered California web portal. That was developed on a very ambitious timeline, and we're proud of how far we've come in that system. And in combination then with that system, we implemented a no wrong door approach, which means that consumers can enroll through many portals, online, in person, by phone, by mail, leveraging multiple partnerships. We have electronic verification of income, which again helps streamline the eligibility process, makes it more accurate, and helps improve the process that counties and other partners can use to implement enrollment. We developed an express lane eligibility option for families that were already enrolled in CalFresh, also known as food stamps. We had a hospital presumptive eligibility program that helped people who were already going into a hospital to streamline their enrollment for hospital admissions. And we also had a sort of pre-ACA program called the Low Income Health Program as a bridge to Medi-Cal. And that allowed over 620,000 individuals across the state to be enrolled in Medi-Cal in the Medicaid expansion immediately in January of 2014. We developed pre-populated renewal forms to help people keep their coverage once they've got it. And we changed through our modified adjusted gross income rules, eliminated the asset test for many individuals under age 65. Just also to note about Medi-Cal, our enrollment is year-round, so we encourage eligible individuals to come in and apply through one of these many portals year-round. Our network of Medi-Cal managed care health plans provides access to quality coordinated care. Most Medi-Cal consumers can choose between 2 or more plans. We contract with a total of 22 health plans, which is basically leveraging California's competitive market for health plans. And finally, what we've found has been echoed in some of the consumer statement is that as 2014 and 2015, as more people became enrolled, they learned how to use health coverage and what that meant for people who were previously uninsured. So we were glad to integrate that into our delivery system. Just a few more facts and figures about our Medicaid expansion in California. So as Ms. Kelch mentioned, we had about 7.9 million of our Medi-Cal caseload overall in 2012-13, and it increased to a projected 14.3 million in 2017-18. So we now cover over 1/3 of the state's population in the Medi-Cal program. And again, we estimate about 4.1 million Californians will be covered through the Medicaid expansion. To fund the Medicaid expansion, the governor's budget for this coming year assumes about $20.1 billion, which includes $19.2 billion in federal funds and $888 million in general funds. That's for the upcoming year. And then in subsequent years, in 17-18, the federal funds would be $17.3 billion because beginning in 2017, the state assumes a 5% share of cost for this optional expansion, and by 2020, the state share will be 10% based on current federal law. As far as potential federal changes, we've seen that the incoming presidential administration and leaders in Congress have suggested major changes to the program. At this point, it's not yet clear what those changes will be or when they will take effect. So right now, our governor's budget continues to reflect existing state and federal law. Thank you for the opportunity to be here today, and I look forward to hearing other testimony and can answer questions.
Thank you. We'll go ahead and allow Kelly Green, Director of External Affairs, Cover California, that will open up to questions to the members. Welcome, and please proceed.
Thank you. Mr. Chair. Thank you. One moment. It's on. Oh. There we go. Is that better? Thank you.
That's better. You're on.
Thank you very much. Mr. Chair and members of the committee, my name is Kelly Green. I'm Director of External Affairs for Covered California, which is our state's health benefit exchange. Thank you for the invitation to participate today at the hearing. Through the expansion of Medi-Cal and the creation of the competitive marketplace that's helped to grow and strengthen the state's individual insurance market, affordable health coverage has been brought within reach of millions of Californians. Covered California specifically is driven by a mission to increase the number of insured Californians, to improve healthcare quality, and also to lower cost and improve or reduce health disparities. Since opening its doors in 2014, Covered California has cumulatively enrolled more than 2.5 million people into health insurance. As of June 2016, our current enrollment is approximately 1.36 million active enrollees. Many of these are individuals who previously had not had coverage, either because they could not afford it or could not obtain it due to a pre-existing condition, or they may have had a change in life circumstance or employment that led to them not being able to have access to the insurance prior. Covered California's enrollee population is diverse, and it has a substantial proportion of younger enrollees, and it constitutes a healthy risk mix, which is a very good thing in the individual insurance market. This is not by chance, but rather by design, as Covered California, through its extensive marketing, outreach and sales, through its service to consumers, works very actively to attract and retain enrollees into the Covered California marketplace. About 90% of our enrollees receive federally funded premium tax credits that help them pay for their monthly premiums. The financial assistance covers, on average, about 70% of a consumer's gross premium. So on average, the gross premium is about $611, with the average APTC being $440, netting a $172 average premium that would be paid by the consumer. So federally funded premium assistance does go a long way in maintaining affordability for consumers. Additionally, over half of Covered California enrollees receive financial help to pay for their out-of-pocket costs related to healthcare services right there at the point of service. They're referred to as cost-sharing reductions, and they're available to those with incomes that are below 250% of the federal poverty level, and they can be obtained by purchasing a silver plan. Our plans are on 4 different metal tiers based on actuarial value, and an enhanced silver plan is the way that you can obtain cost-sharing reductions that are federally funded and can help consumers offset some of their out-of-pocket costs when receiving care. We have had many tools for success. Many of our achievements can be attributed to the way that the state implemented and chose to enact health reform. Covered California, through its enabling statutes, has in place the tools needed to play a role in shaping and creating a competitive marketplace in our state, and one that does focus on affordability and quality. Covered California leverages its authority to negotiate with health insurance plans to create that competitive market, and that contributes to the affordability and creates choice and value for consumers. Each year of operation, we have contracted with no fewer than 10 health plans. Again, this helps consumers to shop and select from plans that are offered in their region. For 2017, we contract with 11 health insurance companies this year. And in terms of choice, 100% of Covered California enrollees can choose from at least 2 plans, and over 90% can choose from at least 3 plans in their region. We proactively work to keep premium costs down. We negotiate with plans on health rates, and we have seen improvement in rates since Covered California's establishment. So between 2011 and 2013, California's individual market had a median rate increase of 10.4%, so that's the median. So for many, double-digit increases. In 2015 and 2016, by negotiating with the plans, the statewide average rate increase was 4.2% and 4%, respectively, for each of those years. We do know that rates for 2017 are a little bit higher, and much of that is due as a result of the expiration of a federal program that helps provide financial support to plans who may have sicker enrollee populations in the first few years. That program is expiring, and it is contributing to a rate increase for 2017, among other factors. 2017 rates would be 13.2%. Despite the higher rate this year, the 3-year average over the last years is approximately 7%, which is still lower than the trend prior to the establishment of Covered California. Another highlight to mention is the patient-centered benefit designs, and Ms. Kelch mentioned this in her discussion. We do require patient-centered benefit designs for all of the plans that contract with us. It provides a comparable set of benefits that consumers can review, and it allows them to make apples-to-apples comparisons among the plans that they are shopping for. It alleviates them from having to navigate very complicated variations in health plan designs, and it also, one very important piece of the benefit design for Covered California is that it reduces the number of services that are subject to a deductible. So for example, all outpatient services in our silver, gold, and platinum plans are not subject to the deductible, and even in the bronze plan, enrollees can have 3 doctor visits without being subject to a deductible. So this helps to bring value to the plans, particularly in the bronze tier, where individuals may want to have a lower cost plan but can still have access to care without having to pay a big deductible up front. We work with health plans, providers, advocates, other stakeholders to update our patient-centered benefit designs, and we're currently in the process of working on our 2018 benefit design. Also, and I believe Ms. Kelch touched on this as well, in California, our individual market is comprised of a single risk pool. Health insurance companies that offer Covered California products must offer the same outside of the exchange, the same product. So as the result of developing a competitive marketplace through our exchange, we also help drive and support competition and improvements in the outside market off of the exchange. And there are as many as 1.1 million Californians that are enrolled in an off-exchange plan, and many of those do benefit from the work that Covered California has done. Anastasia mentioned CalHERS. We have made significant investments in the CalHERS through our partnership with DHCS and with our other partners and stakeholders. So I won't go over that in detail, but do want to mention that we also operate service centers. These are service centers in Fresno and Rancho Cordova. They're staffed by approximately 850 employees that provide direct service to our Covered California enrollees, both for pre and post enrollment, for education, for support and assistance with questions about eligibility, and others. We process millions of calls each year at the service centers. For marketing and outreach, again, in order to maintain a healthy enrollment pool, we invest quite a bit in marketing and outreach and sales to make sure that consumers are continually aware of the products available to them through Covered California and the potential financial assistance that they could qualify for. We also have some very other innovative plan management requirements for our plans that really work to improve health disparities and, again, to empower enrollees to participate in their health care. So I'll just close by saying that obviously with a transition to a new Congress and a new administration, that many questions have been asked about what those changes might mean for Covered California and for the enrollees that we work with. So first and foremost, we do remain focused on enrolling and renewing consumers into their health coverage. We're in the midst of a fourth open enrollment period right now that actually ends at the end of the month. Consumers are currently renewing their plans and enrolling into coverage for 2017, and we want to make sure that they are aware that despite the discussions that are occurring in Washington, that health plan rates for 2017 will not change. Financial assistance is still available to them. The penalty for not maintaining coverage is still intact. So our energies have really been focused on trying to get those messages out to consumers and try to continue to support and promote enrollment. We've been very proactive to get the messages out to quell confusion or uncertainty about whether or not to enroll, and we'll continue to do that. And in final closing, as policies at the federal level emerge and a clearer picture begins to emerge of what policy changes might be proposed, Covered California is not able to advocate either for or against any particular policy, but we do have a lot of information and lessons learned that we can certainly share and offer perspectives in the form of technical assistance. And so we look forward to working with you and others as policy changes are discussed. Thank you.
Thank you both for your presentations. I'd like to open up to any questions to any of the members. Senator Leyva.
Thank you, Mr. Chair. Thank you, ladies, very much. I had a couple questions and a comment. Ms. Dodson, the 22 health plans that you referred to, are those 22 choices that people have?
It depends on the county. So in many counties, there are 2 health plans. There's a local initiative, and then there's a commercial health plan. In some counties, there's just 1 health plan. It's a county organized health system. And then in some counties, San Diego and Sacramento, I believe there are 5 health plans.
So there's 22 plans throughout the state of California.
Correct.
Got it. Thank you very much. And Ms. Green, I want to say, number one, I think that Covered California did an extraordinary job of implementing the ACA as navigators. We got to go through some of the rough ride, but we were always greeted with much help and enthusiasm, and I think you all did a terrific job. I had a question about the 11 health insurance plans. Who are those? Is it the same way as Ms. Dodson said? It's throughout the state?
It was similar. For Covered California plans, we have 19 different rating regions. Depending on the region you live, you would have access to a certain number of plans. So every region, every consumer has access to at least 2 plans. The majority have access to 3 or more. And so depending on where you live, the availability of the plan would vary.
Got it. And I just wanted to state for the record, we've heard so much about rate increases and how high they are and how bad they are. As someone who sat on a trust fund and negotiated benefits for 60,000 grocery workers, before the ACA, we were facing 18% increases every time we negotiated benefits. So that meant that, which was usually every 3 years when the contract was up, so that meant that our members were either taking a pay cut because we couldn't afford to, there's only so much at the bargaining table, and it either went all towards health care, or they took a pay cut because their health care increased what they were paying out of pocket, so it was a decrease in their wages. So even though it's 13%, the average over 3 years of 7% is really remarkable. And I just think that a lot of people don't know that just because they're not intimately familiar with it. So the ACA has helped not only the uninsured, but helped the insured have more affordable rates. So thank you, ladies.
Any other questions? Yes, Senator Newman.
This one. First of all, thank you both for your testimony. And I guess it's a question for Ms. Green. We know precious little about what a replacement for the AC might look like, but one element which seems to come up quite often and is presented as a solution or part of it is the ability for insurers to sell insurance across state lines. Could you talk to that a little bit and what the impact might be on California?
Well, Covered California doesn't have an official analysis of what that might look like. We are in the process of seeing what kind of policies emerge, and when we have a clearer picture, we might be able to provide more information and technical assistance at that time. I can say that from the discussions, just in following at a high level, a major question to think about in regards to that is what type of a regulatory scheme there could be in that under that scenario. Here in California, as was mentioned, we have 2 regulatory bodies here, and so a major question that could be contemplated moving forward under that type of a proposal is to what degree would the sales across state lines impact the way that Covered California regulates its plans, and to what degree would regulation apply to plans from other states. But in terms of other analysis, I apologize, we don't have that at this time.
Yes, Senator Mitchell.
Very quickly, sir. Ms. Dodson, we had our first budget committee hearing yesterday, and I asked Department of Finance if the governor had responded to the House Majority Leader's letter, inquiry that he sent to governors all over the country, all the governors, asking them about their ideas for an ACA replacement. We were told that yes, Governor Brown responded. Do you have any idea if the department was involved, or if the governor was specific in terms of his ideas so far about what could be a replacement for California?
So essentially, the administration at this point, as the deliberations begin, we stand ready to build on what has worked, support changes and efficiencies where appropriate, and play a constructive role to protect and enhance the lives and health of Californians within the fiscal constraints facing the state. So that is, a paraphrase of what was in the letter. Yes.
He didn't get into specifics about, okay, fair enough. Thank you.
Mm-hmm.
Thank you. A couple comments, and they may turn into questions. Let me, just to kind of follow up on Senator Leva's question with regard to Medi-Cal. First of all, I can tell you that I believe California has done an incredible job with regard to its Medicaid expansion, but providing coverage to a third of the population. We have obviously 3 systems. We have the COES, we have the 2-plan model, and we have the geographical model, and they're scattered throughout the state. But within those, even within the COES or the 2-plan or the geographical, you have numerous plans that are competing, that are being available, whether it's IPAs, whether it's managed care, whether it's health plans, et cetera. So there is a lot of access, but more importantly, there's a lot of availability of various types of plans. I think probably the biggest problem we have is not the ability for plans to be available, but it's more so the access to providers in particular areas of need, like the Central Valley or the inner city. That's probably a bigger problem than it is to actually get insurance. Covered California, I think, has done an incredible job, mainly because it's an active purchaser. It has the ability to compete, but more importantly, to get the best possible rates with the best possible outcomes, that is. And what's interesting is you had mentioned there's been a 4.2% and a 4%, but I believe the 13.2%, and this will be a question, and forgive me for not writing the notes down, but I believe it's because of some of the federal offsets that weren't available. Or explain to me how that 13.2% came about.
Yes, so there, upon implementation of the Affordable Care Act, there were a few mechanisms in place that were designed to help create stability in the marketplace. As carriers were attempting to rate and evaluate what their pool might look like, there were a lot of unknown questions. So one of those mechanisms is a program called reinsurance, and that is where plans are assessed a fee, and the monies generated from those fees are distributed to plans that have a sicker enrollee population and therefore may have higher costs. That the reinsurance is expired, and the plans, in developing their rates, understanding that those funds that they would be going away, base their rates in part to adjust for the lack of federal reinsurance funds that would be available. So of the 13.2%, the loss of the federal reinsurance program was a significant driver in seeing that bump for the year. And so for many, it is a one-time adjustment. So you may see 2017 being referred to as a transitional year for rates, and it's due in large part to that.
And I kind of anticipate that was the case. So we're looking at 4.2 of 4%, overall of 7% within the last 3 years. And I would anticipate that if we continue at this rate, you will not see a large spike like a 10% or a double-digit increase in the next calendar year, of course, unless it's totally, the federal money is drawn away and then the markets will be unstable at that time. But would you anticipate the way we're going now that we would have less than a double-digit increase next cycle?
We're, at this time, our plan management division is working closely with the carriers for 2018 contracts, and rates will be a part of that. I think at this time it is unknown what the rates may look like in 2018. Certainly, uncertainty in the marketplace doesn't necessarily help in that regard, but we may see in the weeks and months to come where those negotiations may land.
And I believe a big part of controlling costs would be, as you had mentioned, having a healthy pool of individuals. What would you anticipate would happen to rates if we have the individual mandate that would go away? What would it do to the market?
Well, the individual mandate is a very important incentive for enrollment, and if it were to go away, it likely would have a significant impact. There have been reports that estimate what that impact might be. If the individual mandate were to go, I think that would cause concern among plans, just in terms of making sure that to what degree enrollees would have less of an incentive to enroll. Subsidies play a large part in decision-making for enrollment as well, so it's a little unclear at this time, but it could have a significant impact.
Thank you. I have no further questions. Just one more, Senator Leyva.
Thank you, Mr. Chair. I want to piggyback on your federal reinsurance question. My question is, did it come before Congress to re-up the reinsurance fee? Could that have been, I know it's coming to an end, did they have the ability to keep it going?
I believe that the ability, yes. Whether or not it has come, to what degree it's come up for discussion, I'm uncertain. I know that there have been discussions about reinsurance and the impact that it would have to go away. If there were any formal proposals, I apologize, I'm not aware at this time.
That's okay. I just want to be clear that I think, without being too partisan, our president-elect, part of what he ran on was the fact that people's insurance rates were going up significantly. Obamacare rates were going up significantly, but I think that is in large part due to this reinsurance going away, and I just don't think most people know that that is the problem, and just not sure if it did come before Congress and if they had the ability to vote on it or not.
So I may be able to answer it. Correct me if I'm wrong. I may have my staff also give me some information. If I do incorrectly give you the answer, then we'll get it to you. But if you look at the act in itself, there's various things that are in statute that we knew were going to happen, like the Medicaid expansion was going to phase out the 100%, or it's going to go to 90% after, I believe it's 20, is it 2020?
2020.
2020. The reinsurance, we knew it was going to happen, and money was put there at first because of the inability for us to figure out what the risk pool was, so we knew that was going to go away. But I would also say that in California, we have had amongst the absolute lowest increases over time because of what Cover California has done. We have had some of the best options and the most options available. Granted, we have the various rating regions. Some of the rating regions, it's tough just because it's hard to get plans to go there because there aren't very many providers. But compared to the rest of the country, we have, I believe, done an incredible job and a very good job, mainly because of these two entities here in the state of California. Anyway, I'd like to thank you for your presentation. No other questions from any of the members or myself. What we are going to do, we're going to skip item number 5 because we do have individuals that do have to leave by 4 and 5. So we're going to, if you don't mind, we're going to go to the provider impacts. We're going to have Carmen Morales, nurse practitioner. We're going to have Sarah Mueller, Vice President of External Affairs, California Association of Public Hospitals and Health Systems. We're going to have Steve Schilling, CEO of Clinica Sierra Vista and member of the California Primary Care Association. And we're going to have Sue Benham, Vice President, Chief Philanthropy Officer of Dignity Health. We can figure out who's going where. And we are going to come back to panel number 5, but there's some individuals. So why don't we let the individuals that have to leave first go? And I believe that's Carmen Morales. And is it, who else? Who was the other one that needed to leave? Who? Sue? So whoever has to leave first, go first. Okay.
Thank you very much. Good afternoon, Chairman Committee, and also Assembly Member Arambula. My name is Sue Benham. I'm Vice President and Chief Philanthropy Officer for Memorial Hospital. Memorial Hospital is part of the Dignity Health System, which is the 5th largest hospital system in the country, with 32 hospitals in California. Our sister hospitals in Kern County are Mercy Hospital Downtown and Mercy Hospital Southwest. I'm here to speak on behalf of Dignity Health Memorial Hospital, which is a private safety net hospital and a member of PEACH. PEACH is a statewide network of private community safety net hospitals in California. Dignity Health is the largest provider of Medi-Cal services in California, representing about 10% of all Medi-Cal across the state. Specific to Bakersfield, over 850,000 people live in the Memorial Hospital community area, which has grown by 28.2% in the last 10 years, more than, more than twice as much as the state average. Together with Mercy Hospitals, Dignity Health employs nearly 2,000 people in the area. With 426 licensed beds, Memorial provides essential health services, including a full-service emergency department, an accredited chest pain center, a nationally certified stroke center, a pediatric intensive care unit, and other important services. For Memorial Hospital, our patient mix is 31.4% Medi-Cal, 40.8% Medicare, 25.1% commercially insured. The remaining 2.7% is self-pay uninsured. The Affordable Care Act has been tremendously successful in terms of coverage expansion throughout the state. Most of you already know the numbers. Under the ACA in 2017, 5.5 million Californians gained coverage, 4 million through Medi-Cal expansion, 1.4 through Covered California. In Kern County, more than 113,000 people gained coverage under the ACA, with more than 95,000 gaining coverage through Medi-Cal expansion, and nearly 18,000 gained coverage through Covered California. In addition to the great strides gained in coverage expansion, the ACA provides a balanced approach to challenge providers to improve the quality of care and to work together within our own communities to improve the health of individuals and populations. This tactic has resulted in healthcare remaining a stable industry, providing well-paying and meaningful employment opportunities even during the recession. Dignity Health supported the passage of the ACA and has actively engaged in the measure's implementation because we believe coverage is important and will improve the health of our communities. While we acknowledge the ACA was not a perfect bill, if the ACA is repealed without a viable bill to replace it, the impact on hospitals across the country from 2016 to 2028 will amount to a net negative impact of $558.2 billion overall. Repeal without a replacement of the ACA will result in a devastating blow to providers. For Dignity Health hospitals in Bakersfield, the combined impact would amount to $92.4 million loss to Memorial and Mercy hospitals over the next 10 years. The magnitude of these cuts is not sustainable and would likely be absorbed by limiting our service lines and programs, ultimately affecting access to critical care services in our community. Healthcare is not a partisan issue. We are grateful for this committee's work to shed light on healthcare coverage and the impact the ACA has had in California. Today, as we sit in Representative McCarthy's district, we are grateful to him for his willingness to work with us and to remain in dialogue with us, as has occurred over the past several weeks. He has been open and collaborative as he works in Congress to find a constructive solution. Thank you.
Thank you. Who else needed to leave before 5? Wasn't? Okay, if you can go first. Or next, please, present and state your name.
Can you hear me? Technically challenged.
You're on. You're on.
Hi.
Hi.
My name is Carmen Morales Board. Mr. Chair and members of the committee, thank you for the opportunity to speak with you today. I've been a nurse and a nurse practitioner at Kern Medical for 25 years. I'm here today because I see how the Affordable Care Act improves the lives of our patients. We just can't afford to lose the gains we've made. Working on the front lines at a safety net hospital, I'm very familiar with what happens to people who don't have access to affordable coverage. I'm a certified diabetes educator. Before the Affordable Care Act, I saw a lot of people who had lost a toe or a foot to diabetes. They couldn't afford to see a doctor or to get their medicines, and out of desperation, they went to the emergency room for treatment, which, as you know, is a costly alternative. The ACA provides access to preventive care. That's the key to successfully managing chronic diseases like diabetes. Now my patients are healthier, they can continue to hold down a job and be productive. I want to continue to write prescriptions for medicine and for diabetic shoes, not wheelchairs. Lack of access to quality, affordable health care insurance kills people. The ACA improves the lives of the people in Kern County, and we need to keep it in place. Thank you.
Thank you. What I'm going to have to do is make one other change. I apologize. I found out that an individual in the consumer and health advocacy had. Well, we're going to go ahead with this panel for a little while longer, but we'll try to get that other person in because they have to leave by 5:30. So we got a little bit more time. So let's go ahead and go on with the 2 next presenters, if you don't mind. Who would like to go first?
I can. Thank you.
Can you hear me now?
Now we can hear you.
Okay, my name's
Like
Steve.
you sound like a commercial. Can you hear me
Okay.
now?
I can hear me now. My name's Steve Schilling. I'm the CEO of Clinica Service, and I would want to read a quick statement here. But first, I want to say that in our county of about 850,000 people, we represent 2.5% of the state's population. And sitting here in our chambers today are 5% of the state legislature. And I wanted to just thank you for making the trip here to join us in our beautiful county. And it's quite an honor to have you here. I want to talk for a second about community health centers because they have been a player in safety net services in California for a long time, pre the ACA, during the ACA, and whatever is left after the ACA, we will still be here. The value of community health centers is more apparent now than ever. Over the past 5 decades, we have successfully built one of the finest patient-centered healthcare systems in the nation. Millions of Californians, including those in the ACA, 1 in 7, choose to come to us for care. They trust us, they believe in us. Now, post-election, our future and the future of healthcare in the state of California seems uncertain. Speculation runs rampant, but facts do not. What we do know is that change is certain. Healthcare coverage for our patient population and the healthcare financing that keeps our doors open are at stake. It is a very dynamic situation that does not instill a lot of confidence in the future. But as I thought about the history of our movement and what we have already accomplished, I am encouraged because I know that we will endure and ultimately prevail. It may be a different path than the one we're on today than we expected, but we will continue forward. Our patients will still have somewhere to go for care. They will not be left out in the cold, not only because we are good people committed to low-income communities, but because we have built a nationwide system of care that forms the foundation of health in our local communities. We are efficient and effective. That cannot be ignored or abandoned. In rural communities, we are some of the only healthcare providers available. In Lassen, Mariposa, Yuba counties, which are all rural, we provide care to more than 70% of those counties, persons. Medicaid beneficiaries. In agricultural counties like Merced, Kern, and Tulare, where our nation's food is grown, half the county is on Medicaid and come to our health centers for care. In urban communities, we are the healthcare backbone of low-wage industries that keep our cities moving. Highly vulnerable communities like children living in poverty, people who are homeless, and people who are living with HIV rely heavily on us for care. The patients we serve in these communities are among the sickest and most medically complex as well. Working in these communities has forced us to overcome significant challenges while continuing to deliver excellent health care at the local level. We've been doing this for decades. Let me just summarize by saying a little bit about what we have accomplished here through the ACA. At our own organization, since 2012, when we began to roll out Medicaid expansion in covered California, our uninsured rate has dropped from, within our own organization, has dropped from 60,000 patients to 25,000 patients, from 39% of our total patient population down to 16%. Our Medi-Cal enrollment has grown from 72,000 patients that we serve at Clinica to 115,000 patients that are now on Medi-Cal. In other words, an increase from 46% of our patients to now 68% of our patients. What that means is that instead of relying entirely on a federal grant that sometimes is in jeopardy, including this year, and that's why I wanted to make the statement about health centers, we have seen a huge increase in revenue through Medicaid and through Covered California. That keeps us alive. And as we potentially watch our federal support diminish, our reliance on the ability to earn income by seeing patients who compensate us for care is more important than ever. And what you need to understand is we provide in community health centers throughout all of your districts care to about 7 million Californians receive care at health centers. We provide right now, I believe, 58,000 full-time jobs at community health centers serving 7 million Californians, many of those uninsured still, many of those on Medi-Cal, many of those on Covered California. So we are a backbone provider for you in this state, and we've got to make sure that the advances and the improvements that we've seen because of Covered California and the ACA remain in place. We could not sustain the level of services we're currently providing at all if we see the kinds of cutbacks that we're thinking may happen if there's an unraveling of this very important act. Let me talk a second about Covered California and what I am called a certified enrollment entity. Now, those of you in the Covered California world know what I'm talking about. As an entity that provides assistance and help to patients to sign them up for Medi-Cal and for Covered California, we ourselves, our own organization, have enrolled 18,000 people into Covered California in our service districts, which include Fresno and Kern, and 54,000 people into Medi-Cal. We have about 30 staff that are funded sometimes by assistance from the endowment, I know they're here in the room, and by Covered California, who has helped entities like ourselves sustain a staff to go out there and enroll the folks that you heard earlier today on these panels. Clinica today is the second most productive enrollment entity in the state. In the first year, we were #1, and for the last 2 years, we've been #2. It's a huge number of people, and why that is, that's good news and bad news. The good news is we work like hell and we enroll a lot of people. The bad news is we have a lot of people to enroll and a lot of eligibles in this Central Valley. I know Assemblyman Arambula understands exactly what I'm talking about. We need this act to stay in place. We need potential changes to be sensitive to the nature of the system we have created around this act over the last 3 years. We followed we played by the rules. We did what we were asked to do. We grew the program. We enrolled the populations. We have raised the expectations. There are all kinds of matters that are kind of around the aspects of the ACA that are already beginning to fray a bit at the edges, and I'm getting very concerned about that, one of which is the workforce issue. As we build workforce in California, and as your state legislature last year in the budget added $100 million to the OSHPED program to enhance workforce, especially a problem here in the Central Valley where we have half of the providers that you have in the more urban centers of California. That act was to go into place on January 1st, and the governor, and I can imagine if I were the governor and I were staring down the gun barrel of a repeal of the Affordable Care Act, I'd start to get a little dicey too, but he pulled that back, and he's held that off now for an additional year. So that $100 million that was going to be used to improve the medical education, graduate medical education of family medicine and primary care providers has been put on the back burner waiting to see what happens. That's extremely tragic here in this valley. I run a teaching health center, a family medicine residency program that I took over when the county of Kern decided to go in another direction, and we kept that program alive here in Bakersfield. We are training today 18 family medicine residents. We're going to graduate our first class in July, and we're going to match our next class next month for beginning in July. So we are working to create a workforce opportunity here in the valley to change around the dynamics that we deal with here. We can have coverage coming out our ears. If we don't have providers to provide it, we've got nothing. So we can't lose programs like that. And although the governor probably was being very cautious in his efforts to hold back this particular thing, it really is going to cause a disruption to us, especially if the teaching health center funding at the federal level is susceptible to damages by the new Trump administration. The other thing that happened the other day, we've worked like heck for 3 years. Your legislature has unanimously, for 3 years, approved a piece of legislation to allow marriage and family therapists, MFTs, to become behavioral health providers. You folks have done your job. For 3 years, the governor vetoed this bill, except last year he signed it. So that law was to go into effect again on January 1st. He now has held that law off for another year. So now we are going to be tightened up, hamstrung, if you will, to be able to provide the important behavioral health services that our populations really need here so that we can integrate that into the services we provide in medical and oral health and behavioral health and all the health prevention and enabling services we currently provide within community health centers. So we're already seeing some of the impacts of the Affordable Care Act being on the burner, if you will. We can't see many more of those things, or we're going to begin to have to constrain the services we provide to the populations we care for. I am so happy you came. I'm so happy you gave us a chance to speak to you, and you heard from our people and our residents and our patients. And thank you for listening, and Godspeed as you begin to work with the federal government as you figure out a way for California to maintain these very important programs. Thank you very much.
Real quick, interesting percentage and numbers. It was, what percentage of the population is here compared to the percentage of the legislature that's here?
We have 840,000 people, 2.4% of the state's population in Kern County. You folks represent 5% of the legislature, so we doubled up today. Thank you very much.
That just goes to show you how important this county is, right?
Yes, it is.
All right.
Yes, it is. And we appreciate it.
Great numbers. Anyway, we're going to move on to Sarah Mueller, Vice President of External Affairs, California Association of Public Hospitals and Health Systems. Welcome, and please proceed.
Thank you, and good afternoon, Mr. Chair and members. My name is Sarah Mueller Hesketh. I'm the Vice President for External Affairs at the California Association of Public Hospitals. CAPH represents 21 different public health care systems that include all of the county-owned or county-affiliated systems in our communities, as well as the 5 University of California medical centers. Our systems play 3 critical roles in their local communities. First, they're major safety net providers. Although they represent only 6% of hospitals statewide, they serve 25% of the state's Medi-Cal beneficiaries and 40% of the remaining uninsured. Medi-Cal and low-income populations represent the core constituency of the patients who our members serve every day, particularly in the primary care and community, in the specialty care settings, where they can develop ongoing relationships that keep patients healthy and out of the emergency room. Second, our public health care systems are providers of critical community services and are often the place that anyone will go in the event of a major emergency. Together, they operate more than half of the Level 1 trauma centers and half of the burn centers in our state. Third, public health care systems are educators, training more than 57% of the next generation of physicians. So even if you don't get your care at a public health care system, chances are you get your care by a doctor who was trained at one. Our journey to prepare for coverage expansion under the ACA began under difficult circumstances. In 2010, our systems had experienced significant budget cuts and dramatic increases in uninsured care as part of the Great Recession. A provision in the Affordable Care Act allowed states to expand Medicaid early, and we used this opportunity in California and within our systems with great results. Beginning in 2011, public health care systems helped lead the launch of the Low-Income Health Program, enrolling individuals into coverage prior to their coverage eligibility in 2014. Across the state, more than 700,000 individuals enrolled, and 89% of those individuals enrolled were in counties with a county public health care system, including here in Bakersfield, where in Kern County, more than 10,000 enrolled prior to coverage expansion. Why are coverage and primary care so important? Because, as Dr. Atul Gawande notes in his latest article, patients are, quote, more willing to seek medical attention for potentially serious symptoms far sooner instead of putting them off until it's too late. This reduces mortality rates, keeps people productive and working, and saves emergency rooms for true emergencies. With patients enrolled in early coverage programs, public health care systems were able to take on the challenge of making care better, more coordinated, and more efficient. Between 2010 and 2015, public health care systems expanded primary care capacity by more than 20%, reduced the rate of diabetes patients being hospitalized for short-term complications by more than 20%, and reduced hospital-acquired infections and improved inpatient safety. As part of this effort, the County of Kern expanded its primary care clinic hours by nearly 50%, reduced wait times for patients by 40%, and they developed a care navigation program for high utilizers in the emergency room that led to a drop of 50% of ED visits among participants. Although public health care systems and many other safety net providers around the country, around the state invested heavily to prepare for the Medi-Cal expansion, full implementation in 2014 brought greater enrollment and greater need than any of us had anticipated. Statewide, as we heard, more than 3.7 Medi-Cal enrollees have signed up for coverage. And today, more than 560,000 of Medi-Cal expansion enrollees get their primary care at public health care systems. We serve even more in the hospital and specialty care settings. In Kern County, that includes 95,000 Medi-Cal expansion enrollees that receive their care at local providers. The implementation of coverage expansion has brought more stability for public health care systems, and it's created an opportunity to shift towards more proactive and preventative health care. With the majority of our patients enrolled in coverage, our systems can now focus on improving healthcare outcomes rather than addressing the urgent need that might be in front of them or presenting in the emergency room. Our members have been able to expand high utilizer programs, offering intensive services to our most vulnerable and high-cost patients and helping them improve their health outcomes. They've expanded chronic disease management programs so that both patients and providers can work together in monitoring and improving health. And they're testing new low-cost innovations that don't require an in-person visit, such as email and phone consultations among providers and telehealth services. Again, we're only able to do this because the vast majority of our patients have healthcare coverage. And we can coordinate their care through primary care teams, schedule follow-up appointments with specialists as needed, and proactively monitor their health. All of these efforts seek to better align payment, improve healthcare outcomes, create more efficient systems, and lower healthcare costs. Consequently, the repeal of the ACA would erode much of the progress that we have made to improve care and keep our patients healthy. We are concerned that the repeal of the ACA without an immediate or adequate and simultaneous replacement could leave millions of Californians without coverage, returning them to a place of fear of needed medical treatment that may cost too much. A repeal, especially a repeal of the Medicaid expansion, would undo a lot of the good work that California has embarked on. And we are paying particular attention to the Medi-Cal program, given it's the foundation of the patients that we care for. For public healthcare systems, a repeal would result in more than 560,000 of our patients losing coverage. The preliminary revenue estimates associated with these patients and all of the Medi-Cal expansion patients that come through our doors would result in an estimated loss of $2 billion a year in federal funding. The impact of what is at stake is best illustrated with the patients who our systems care for. Last week, I learned about Sonia, a 40-year-old certified nursing assistant who receives care in one of our systems not too far from here. Her family has a history of breast cancer and hypertension, and last week she was waiting to hear whether or not a biopsy had detected cancer. She shared with our local leaders that being enrolled in Medi-Cal helped her avoid having to make the difficult decision of getting an expensive test or working to pay the PG&E bill to stay warm in the winter. She got the biopsy done, and just a few days ago, we learned that she does have cancer. As she embarks on her recovery, we are grateful her Medi-Cal coverage will allow her to focus exclusively on her health and her recovery, and will cover all of the major costs of her treatment. Sonia's experience is a reminder of how quickly one's health status can change and how important it is to maintain high-quality access to affordable coverage. A repeal of the ACA could leave Sonia and millions of others without the care that they need and would impede our providers' ability to do all that we can to improve their health. We urge that any repeal of the Affordable Care Act preserve the Medicaid expansion and include a simultaneous replacement package so that everyone that's enrolled can maintain access to affordable coverage. Thank you.
Thank you. Is there any questions from any members? At this time, yes, Assemblymember Arambula.
So a couple comments, if I may. First, Steve, you know I'm a big fan of pretty much everything that you guys do with FQHCs, but particularly your ability to start training and retaining people in the Central Valley. It's imperative that we do it, and I thank you for taking that burden on. The question I wanted to focus on is for both Sarah, Sue, and Steve. And you know, we focused a fair amount on the patients, but we haven't talked about the jobs yet. We haven't talked about what's going to happen in my community if we're taking away coverage. How many people are going to go without jobs? And in communities like mine that are struggling to get ahead, we've heard estimates of 24,000 jobs will be lost in the San Joaquin Valley. That's more jobs than were lost during the drought that we just went through. So my question to you guys is, I don't want to be paranoid about what they're doing in DC, but have you postulated about what will happen if there is a repeal and what effect that would have for your company and for the people who are employed at the places where you work?
Well, let me just react to that. And I have a data piece here for you. The UC Berkeley Labor Center report estimates 209,000 jobs in California would be lost if the ACA is repealed. I can't speak to exactly what it would be here within Kern County, but I know in the community health center world around the state, we're envisioning somewhere in the neighborhood of 5 of those 58,000 jobs would be lost. What am I doing? Well, I'm a CEO of an organization that employs 1,250 plus people in 70 locations in these 3 counties, and I'm going pretty slow right now. As staff come to me with replacement requests, as they talk about potentially refilling positions, having just come back last week from Washington where I spent some days there speaking to some of the legislators that have been referred to, I'm a little nervous and I'm a little cautious and I'm going a little bit slow in terms of refilling vacancies or adding on to new programs or thinking about expanding into new disease chronic models that we could be creating and working on the kinds of things that the previous speaker just was talking about. So we're taking a little bit of a cautious approach right at the moment. It's not good. I'm not happy to be there. It's very much like what the governor is dealing with when he's talking with you about his state budget. It's the same kind of a thing. We're all kind of being kind of pushed back against the wall right at the moment, and we're just treading very slowly and waiting to see how this unravels itself from this very complicated basket that it's become. They know they would like to keep certain portions of this program, the pre-existing conditions, the lifetime benefits, the kids under 26 years of age. But as they begin to pull out those strings from this nest of benefits, they're tied on to all kinds of other things. So there's a great deal of confusion right now in Washington and uncertainty and inexactness about what they're going to ultimately do. And in the meantime, I think we're all kind of like on pause a bit, unfortunately.
If I can just make a comment about one other thing that you mentioned, and I'll end my comments if I can. There are many of us within the legislature who shared your concerns about Song Brown and the decrease in funding that we have. And as one of them, I can tell you that I will be standing up and making sure that we're fighting to increase the number of providers that we have here in the Valley. It's one thing to hand out insurance cards. It's another thing to actually access care. And I know how important it is to marry both those thoughts here in the Central Valley.
Exactly. Thank you. That's wonderful.
Okay, seeing no other questions, I'd like to thank all the panelists for participating, and we are going to move on to item number 5, consumer and health advocacy. We have, I believe, the individual that needs to leave, we'll let him go first. That's Tony Eiton, MD, JD, MPH, Senior Vice President of Healthy Communities, the California Endowment. And I do apologize for that, but we'll let you go first.
Thank you very much. Good afternoon, Mr. Chairman and fellow members. It's a long afternoon, and it's great to be here in Bakersfield with my colleagues Sarah Reyes and Annalisa Robles. Tony Eiton from the California Endowment. And I'm here to talk about a little bit of data that's kind of interesting that you may have seen a little bit of in the newspaper yesterday. But I want to tell you why it's important to this particular conversation. I am a physician, public health practitioner, spent most of my career working on racial and ethnic health disparities. And recently, in the work of doing racial and ethnic health disparities, you're always trying to close the gap between African Americans and whites, between Latinos and whites, between various other groups and whites. And recently, we've been recognizing a phenomenon that may make that whole paradigm disappear. And it started essentially with a recognition by an economist, of all people, that there is an increasing rate of mortality in middle-aged, working-class white Americans. And there's been a number of studies across the country that have looked at this phenomenon, and we decided to take a deep dive into this question in California for a variety of reasons. One is that we believe that inclusion means inclusion of everybody. And the work that we do tries to improve the health status of all Californians, low-income Californians, middle-income Californians, high-income Californians, all races, religions, creeds. So when we took a deep dive into this question, one of the things that stood out immediately, as a matter of fact, it screamed at us, was that in this region, the 4 counties that include Kings, Tulare, Kern, where we are right now, and Fresno, have this incredible phenomenon occurring today as we speak. And I wanted to show you a little bit of that phenomenon. I want to remind you that the mission of the California Endowment, we're the largest health foundation in the state, is to expand access to affordable quality health care for underserved individuals and communities and to promote fundamental improvements in the health status of all Californians. So, let me go to the first slide I want to show you and just give you sort of the headline here. The headline is that it's a crisis of white death in the central and southern San Joaquin Valley of California. And the reason that this is particularly relevant at this time is that the irony of this is that this is the very constituency that voted overtly to eliminate the Affordable Care Act. And without an understanding that there is an invisible crisis in the health of this very constituency that is benefiting and is absolutely dependent on the Affordable Care Act to essentially eliminate this health crisis. So I'm going to tell you a little bit about the health crisis, and then I'll go away. So middle-aged white Californians in the Central Valley are dying prematurely at unprecedented rates. And this is not to discount the health crises that exist in the African-American community, the Latino community, and other communities, but there's this notion that somehow whites are immune to this. So they're dying at unprecedented rates. They're increasingly dying young, in their 40s, their 50s, their 60s in some cases, and there's some data that I'm including for the record that you can see even in their 20s and 30s. In fact, there's an 11% increase in mortality among middle-aged whites living in Kern, Tulare, Kings, and Fresno County. I'm going to come back to this statistic in a moment, but it's important to note that these deaths are preventable, primarily with good access to health care as that cornerstone of that prevention, and we're talking about access to mental health services, behavioral health services, substance abuse treatment services, and the like. Those services are critical to get on top of this epidemic that I'm going to tell you a little bit more about. The phenomenon of rising white death in the Central Valley may presage a larger and more devastating phenomenon statewide. The takeaway from our recognition of this phenomenon is that this is the worst possible moment to be withdrawing access to health care for people in the Central Valley. It's the exact opposite response of what we should be doing. I want to be very clear that the findings that I'm sharing here are preliminary, although they're extremely solid. We're going to investigate this phenomenon throughout the entire state, but when we saw the Central Valley data, we realized that it would be unethical to sit on this data. This is data that people need to understand. We need to be engaged in a strategy to actually reverse this trend. And just to give you some context, in the world of death, people in public health that study death, like myself, we, for the past roughly 100 years, have been looking at declining mortality rates, with a couple of exceptions, the HIV/AIDS crisis, the 1918 flu. But for the most part, every year we expect to see a decline in death rates. And in California, in fact, for the past 20 years, we've seen a decline in death rates. We've seen a decline for African Americans. We've even seen a decline for whites, although it's relatively small. In the Central Valley, over the past 20 years, we have seen an increase in death. It's the exact opposite phenomenon that's happening in the rest of the state. It's the exact opposite phenomenon that we researchers expect to see. Okay, so I'm going to show you just some quick data here. And this is basically a summary slide which shows you that on the bottom there is our mortality rates, death rates across California over the past 20 years or so. And then those other lines above that are the 4 counties that I referred to Look at Kern County where we are right now. That's the death rate in Kern County for middle-aged white Californians, and it's climbing. And it's climbing in a way that's really quite spectacular. In Kern County, we're also seeing something even more troubling. Death rates among young white people ages 25 to 34 are on the rise. In fact, the all-cause mortality rate in this population increased 29% between 1995 and 2014. I'm talking about people 25 to 34. Okay, so what's going on? Underlying this crisis, and it's largely been an invisible crisis to date. People have not been looking at this issue. Underlying this crisis is what we refer to as chronic stress. People who feel that they have lost a shot at the American dream. That's fundamentally what they're feeling, so they're losing hope. Diseases, injuries, and deaths that occur when people become depressed, when people lose hope, is that they become depressed, they turn to tobacco, drugs, alcohol for relief, or commit suicide in desperation. These represent these stress-related conditions. In fact, these causes of death are increasingly referred to as deaths of despair. It's these causes of death that appear to be driving increased death rates for middle-aged whites, particularly in communities struggling with economic challenges. This region is known for high poverty, stagnant household income, and declining real wages, as we all know. Economic uncertainty breeds despair and chronic stress. Across the four-county area, fatal drug overdoses have increased by 151%. Viral hepatitis by 180%. Alcohol poisoning has increased 15-fold. These increases far exceed the state averages. In Fresno County, the rate at which middle-aged white adults are dying from accidental drug poisoning has increased by 212% since the 1990s. In Kern County, it's increased 164% over the same period. In Kern, the increase in accidental drug poisoning is even more startling for younger white men ages 25 to 34, with a 248% increase since the 1990s. In Kern County, the death rate from viral hepatitis has increased by 315% since the 1990s. In Tulare County, 167%. Viral hepatitis, as several of our panel members know, is associated with intravenous drug use. The opioid epidemic is a factor, as is methamphetamine, but we can't blame these deaths simply on opioids and other drugs. There's more going on. Suicide and alcoholism are also on the rise in the white population of the valley. In Kings County, the death rate from alcoholic liver disease has increased 31% over the same time period, and in Fresno, that number is 39%. In Kern County, suicides by hanging, strangulation, suffocation among middle-aged whites have increased 133% since the 1990s. These are deaths of despair. When I see numbers like this, I see people who have lost hope, not because of any individual shortcoming, but because we have a system-wide failure. Healthcare is the cornerstone to supporting these people, but it's not the whole solution. We have to recognize these are much bigger problems. These statistics are driven by policies that decision makers have created, or in many cases, it's the absence of policy. And less so in California because we're working hard together to try to solve these problems. But this phenomenon is nationwide, and we need the federal government to recognize this when they're making policy. Okay, so I like to say that our policies are sometimes as lethal as any knife or any gun. In the Central Valley, we know that there's a high level of Medi-Cal dependency. We've seen that over 50% in many counties, on average probably about 15% across the four counties I've told you about. These causes of death scream out for a deeper investment in mental health care, and substance abuse treatment, and behavioral health care, all of which are covered under ACA and Medi-Cal. In this constituency, again, this is the constituency that some of the leaders in this particular region that are working in Congress have been saying that they are advocating on behalf of those constituents. These constituents are dying, and they're dying at unprecedented rates. So we have to work together to actually try to reweave our social compact in California, and a critical cornerstone of that social compact is guaranteed universal access to high-quality health care for all Californians. And I am proud to be in a state that has stood on that principle and has led on that principle, and many of the people sitting before me today are responsible for that, and I want to thank you for your hard efforts in that. We can't give up the fight yet. We have to defend these gains. There are too many lives that are on the line. So in conclusion, I want to say that this epidemic, in concert with a larger epidemic in other populations, African Americans, Latinos, people that have been struggling with poverty for generations, can't remain invisible. We have to recognize that we're all in this together. Too many people are thinking that this new administration is for them, whereas the old administration was for us, or vice versa. It is wrong. When it comes to health, we're all in this together. So we have to work on building a stable and reliable healthcare safety net, and many of the testimony people testifying today spoke to how well California has done in that regard. We also have to look at employment. We have to look at wages. We have to look at transportation, particularly in the Central Valley. All of these things have profound health impacts. With that, I'll leave. I'm happy to take any questions on the data. I have included both the testimony and the data, and there are several newspaper articles from yesterday's news conference that are available to you if you want to get the specific data. We're going to continue this research for every county in California. We expect to find more of this phenomenon, particularly in the northern rural counties. We think that this makes the argument for all of us coming together around health as a shared resource. Thank you very much.
Thank you. What we'll do, because I know you have to leave very shortly, we will open up to any questions to any of the members, if you don't mind, and then we'll go on to the last presenter. But Senator Manning.
Thank you, Mr. Chair. And Doctor, I want to thank you and the California Endowment for your work. Just tremendous contributions. And the focus of your presentation, it's new information. It's not a new challenge, apparently, but it's new information, and it couldn't be more timely. So I want to thank you for your research and contributions. I know it wasn't the focus of your presentation, but could you comment on other preventable chronic disease? I know the California Endowment's focused a lot on obesity, preventable diabetes. There was a New York Times article recently showing increasing trends of preventable type 2 diabetes, and also what used to be called adult onset, now present in teenagers. And just a comment maybe how that corresponds to what you've just shared with us as well.
Yes, thank you, Senator Manning. And it's in the data that I gave you, and it's in our larger report. And thank you for your great work over the years in health. So we're very interested, particularly looking at the full life course, looking at from young children all the way to adults on the issue of diabetes and obesity. And we've spent quite a bit of effort trying to facilitate both access to healthier foods in schools, to water, and cutting out soda and other high calorie drinks, and focusing on trying to ensure that at least in the schools, young people are getting physical fitness and opportunities to recreate. But we think that the big issues that we have to contend with in the diabetes epidemic are beyond healthcare, and they're beyond behavior. They're actually, they include the environments that we design for people. You know, the walkability, the ability to actually use public transportation to get to where you need to go, access to parks, which in Fresno we know is a huge crisis, in certain parts of the Central Valley is a huge crisis for young people. These issues are fundamental issues of access to opportunity. And we typically try to narrowly define them into health behaviors. We don't recognize that when we make decisions about how we design a street or housing, we're having impacts, profound impacts that are decades long on the health of the populations that we're working with. So we're working very closely with 14 communities across the state and others to enlist the participation of community members to prioritize the issues that they care about. Among those issues are opportunities for young people to recreate in a health and safe environment, and to be able to access healthy food.
Well, thank you. And just a final kind of response to that, I think some in the uninformed public think all health trends, it's a question of personal choices and personal discipline. And as you've just described, there's a number of factors where people aren't working in equal environments, and that can be economic, it can be environmental health writ large, as you've addressed. So again, thank you for your work and for the work of the California Endowment, and for your appeal. The takeaway today is that we're all in this together, and that some of the divisions based on race or economics, ethnicity, are ultimately artificial in terms of looking at good public health for our entire state and nation. So thank you.
Thank you.
Senator Mitchell, I believe you had a question.
Thank you, yes. Dr. Eiten, I first met you and heard you speak when you released the research that the foundation did on your zip code determines your life expectancy.
Yes.
And I have always appreciated the foundation's fundamental understanding that it's not just about doing the research, but making sure people know it. So I appreciate the materials today. We should certainly take these back to our Senate colleagues who represent these areas and have them on their desk when they arrive on Monday morning. But beyond that,
please do.
I'm happy to. Beyond that, you know, your PR and media investment and strategy on the previous campaign I mentioned was profound. You all paid for full-page ads and dailies across the country. But in Sacramento, you took out and paid for billboards in the Sacramento airport. Mm-hmm. And so you got off your flight at Southwest and you saw your zip code will help define your life expectancy. And it's that kind of creative PR and media strategy that helps evoke ongoing conversations about these critical public policy areas. I am hoping that the foundation intends to do a similar kind of PR and media investment with this data, because as we said, other than the assembly member, our colleagues from this region aren't here today. Mm-hmm. And so what will it take for every man, woman, and child in these impacted counties to know this data and hold their electeds accountable as a result? Are you all going to make the same kind of media and PR investment?
That's our hope. We believe that this phenomenon is the same basic phenomenon, that, you know, your zip code is more important than your genetic code when it comes to your health, and it shouldn't be that way. But the reason it's that way is because of the opportunity structures that people contend with in their environments and how we stratify people according to their perceived value.
Right.
And many people in the Central Valley don't get access to the same spectrum of opportunities that other people do. We also see the same thing in Los Angeles and in the Bay Area.
Of course.
And our goal is to rebuild a social compact so people understand that we're all in this together. This notion of shared solidarity around our health is critical, because right now, and this debate typifies it around the ACA, the perception is that they are getting and I'm not.
That's right.
And the reality is that we all suffer if we don't work together on health. It's the ultimate nonpartisan issue. Mm-hmm. So yes, we will be continuing to invest in this notion that your zip code is more important than your genetic code when it comes to your health, and it shouldn't be that way. Our goal is to disarticulate the relationship between zip code and health.
And my point is, it takes a repeated assault to help create a mind shift in terms of our thinking and all the isms that we all carry around, who benefits from ACA, et cetera, et cetera. And so that repeated assault, billboards on the street, newspaper ads, whatever, is what I think is critical and where we often fall short. Government doesn't pay for that kind of, you know, public information. And so that's the point I was trying to make. You all did it well on the other campaign, and I hope it continues, because that's the only way we will get the groundswell of support that this kind of culture shift is going to require.
Well, thank you for that feedback. That's very helpful.
Senator Leyva, question, comment?
Thank you, Mr. Chair. Just a quick comment. Outstanding report, Doctor, and you were very politically correct in just mentioning the elected official. You didn't say his name. I want to kind of touch on what my colleague said, to hold your elected officials accountable. Congressman McCarthy is the one who will be voting on this, and he should hear from every single one of you, because I hear from my constituents if they like or don't like something. They hold my feet to the fire. It is imperative that everyone, when 55% of the people in this county are receiving Medi-Cal, he needs to understand that people will die if he's not willing to do his job. Kevin McCarthy, your congressman.
Okay, seeing no other questions, I know you have to leave. I want to thank you for your presentation. Let me just reiterate, I think the first time we met was several years ago when I became chair of the Senate Health Committee, and I was blown away by a presentation you gave on the zip code and the life expectancy, but more importantly, I think you extrapolated, it was like $22,000 more per year increases a life expectancy by a certain amount of years. And that's always stuck to my mind. Here's another piece of information and data that is literally, I mean, an epidemic of white death, a canary in the coal mine, question mark. This is like very profound, and I want to thank you for all that information. Anyway, appreciate it very much. Thank you.
Thank you for having me.
Safe travels back
Thank you.
to the LA area. We're going to now move on to Alexandria Forrester, Managing Attorney for Greater Bakersfield Legal Assistance. Good afternoon and welcome, and please proceed.
Thank you. My name is Alexandria Forrester, and I am the managing attorney at the Kern Health Consumer Center. We are part of Greater Bakersfield Legal Assistance, or GBLA, which is the legal aid organization in Kern County. Thank you for the invitation to speak today about the impact of ACA repeal, and thank you for including the Central Valley in this ACA discussion. The Kern Health Consumer Center helps low-income individuals and families in Kern County find the most affordable and appropriate health insurance coverage available. We work to overcome barriers to eligibility for insurance affordability programs, like Medi-Cal programs, covered California APTCs, and cost-sharing reductions. We work to overcome barriers to health care services like surgeries and prescription medications. The majority of our clients are eligible for subsidized health coverage through Medi-Cal, Medicare, and Covered California. Since implementation of the ACA, the Kern Health Consumer Center has helped thousands of people overcome barriers to health care. Based on the hundreds of cases we see per year at the Kern Health Consumer Center, we have a very strong impression of the impact of ACA repeal in our client base. On one hand, we are proud to provide advocacy and legal services to hundreds of people in need. On the other hand, the fact that some individuals and families require legal assistance to navigate the world of health care and health insurance means, of course, our system is imperfect. However, perspective on the level of imperfection is crucial as we discuss a post-ACA world. To be sure, there are improvements to be made. But do we want to move forward or backward? Back before the ACA was implemented, hundreds of Kern County residents still experienced barriers to affordable, high-quality health care, and hundreds of Kern County residents still came to GBLA for assistance with health care issues. The major difference between that time and the present is simple. Now, the expanded Medi-Cal programs and covered California plans are there to cover the majority of our low-income clients. Loss of federal funding through the ACA will take those options away. I want to share a real story with you to illustrate how coverage through ACA-funded programs can really be a lifeline for our clients. Unfortunately, we don't have time today for me to tell you about all the hundreds of clients we see who are impacted by the ACA, but the stories I'll share are also representative of common experiences within our client population. The couple I'm going to tell you about will not have coverage options if the ACA is repealed. This couple is enrolled in a Covered California Gold plan with Kaiser Permanente, and the plan is not inexpensive, but it is affordable for the couple because they qualify for advanced premium tax credits. Wife has a history of thyroid issues and needs medication to regulate her thyroid condition. Husband was undergoing chemotherapy treatment for prostate cancer. Without subsidized coverage, insurance premiums would be out of reach for this couple. To be more specific, without subsidies applied in real time to adjust the amount of the monthly premium, this couple cannot afford insurance premium payment after paying for the basic necessities, housing, food, transportation, utilities, plus their share of the cost of healthcare services each month. The margin of error for this couple's budget is just razor thin. In addition, without the ACA's protections for pre-existing conditions, coverage would have been impossible. Without treatment for the couple's conditions, they might not have been able to continue working. Without coverage, they might have racked up thousands in medical debt, and most importantly, their lives may have ended prematurely. Federally funded subsidies are critical to making the marketplace work and critical to making marketplace plans accessible to low and mid-income consumers. Loss of federal funding will either cause an eligible population group to be cut from Medi-Cal coverage or will cause certain services to be cut out of Medi-Cal coverage. Any of those scenarios would be devastating to low-income populations that are already struggling with disparate services and outcomes. Without coverage through Medi-Cal or Covered California, many low-income individuals will be uninsured and will not have access to care unless they visit the emergency room. Most of us have been to the emergency room at least once in our lives. A broken arm, maybe a few stitches. Maybe you've experienced that helpless feeling, sitting with a family member in the ER, waiting for them to get care. Emergency rooms are notoriously overcrowded, which means the wait time is often very long. Of course, treatment at the ER is extremely expensive. Now, imagine if going to the ER was your only option for healthcare. You would probably avoid seeking care until it was an absolute emergency. Of course, this scenario is not really a hypothetical. This is the exact problem we see with uninsured individuals. If we move backward instead of forward into a reality where the ER is just one of very few subpar options for thousands of people in Kern County, this issue will balloon once again. Chronic conditions will go uncared for with lack of access to primary care, and people's conditions will deteriorate to life-threatening levels, at which point medical care required is much more complex and exponentially more expensive. The client in my next story could have deteriorated to a very serious extent if not for her coverage through the ACA-funded Medi-Cal Adult Expansion Program. Maria from Arvin was a former field worker. Maria started experiencing frequent, severe, and debilitating migraines. As the headaches interfered with her daily life more and more, Maria worried about the impact of her health on the quality of care that she could provide to her adult son, who is disabled. Maria's doctor told her she needed a CT scan. Maria was uninsured, but had been seeing a doctor at a federally qualified health center, and they used a sliding fee scale for low-income patients. However, the specialist that Maria had to see to get the CT scan did not use a sliding scale fee, and the cost was over $1,000, nowhere near within Maria's budget. Maria delayed the CT scan while she looked for other options and found out she was eligible for Medi-Cal under the Adult Expansion Program. Medi-Cal covered her CT scan and allowed Maria to access specialty care that would have been out of reach before ACA implementation. We have some unique challenges in Kern County. Significant populations struggle with heart disease, that's up to 9.4% as of 2014. High blood pressure was up to 40.3% in 2014. Asthma up to 9.4% in 2014. And diabetes, which was up to 10.3% in 2014. We have a large population of farm workers with fluctuating seasonal income and lack of access to the traditional employer coverage model. At the Kern Health Consumer Center, many of our clients are high-need, high-service utilizing individuals who are trying to manage and treat one or more chronic conditions. For example, we see a lot of clients experiencing kidney failure, which means they require multiple dialysis treatments per week to stay alive. Each treatment costs thousands of dollars. Without the protection for individuals with pre-existing conditions, high-need individuals with marketplace or private coverage will be left uninsured without options for coverage. If Medicaid funding is block granted to the states, those high-need clients with Medi-Cal coverage may lose access to service abruptly whenever funds run out, or may be eliminated from Medi-Cal coverage altogether. Again, these are not hypothetical scenarios. These are cause and effect realities, and the effects are both life-threatening and prohibitively expensive for our clients. To once more refocus our perspective on the amount of people impacted by these realities, 14,500 579 people with subsidized covered California coverage live in the 23rd district, which includes most of Kern County. And approximately 67,000 people are covered under the Medi-Cal Adult Expansion Program in the 23rd district. That's a total of 81,579 people in this district alone with coverage that is reliant on federal funding through the ACA. One of the people with coverage reliant on federal funding through the ACA is our client, George. George is from Bakersfield, and he lost his job after suffering a back injury. Once George lost his job, he was unable to pay for services out of pocket at his local federally qualified health center. But he still needed diagnostics and treatment for his back injury. The Medi-Cal expansion program for adults was a safety net for George. And once he was found eligible for Medi-Cal, he got the MRI he needed. Now George is focused on healing and getting back to work. Without Medi-Cal coverage and without income, George would have never been able to bear the cost of paying for an MRI outright. The potential impact of ACA repeal on an already vulnerable low-income populations in Kern County cannot be overstated. The loss of affordable coverage and the loss of protections for individuals with pre-existing conditions, we will all feel those losses keenly, whether we are low income or not. Again, I want to thank the committee for the invitation to speak today and the opportunity to convey the health advocate perspective and the consumer perspective through the lens of our client stories. Thank you.
Thank you very much. Is there any questions from any of the members, comments? Seeing none, I appreciate the information you've presented. Thank you.
Thank you.
We are now going to move on to public comment. However, it was brought to my attention that an individual that was supposed to speak under the consumer experience couldn't make it, but is now here, Maiku Tapia. If she's willing to or wants to, she can be the first person to be public comment. We can just make it brief. We'll have her come up, and then shortly after her, we will open it up to public comment. As I said, I won't have the timer on, but if we can keep them brief and at or below 2 minutes, I would be very much appreciated, because we want everyone to have the opportunity to voice their concern and or opinion, whether you support, oppose, etc. Anyway, welcome, and if you can just say a few words. Thank you.
Thank you very much. Thank you, board, and thank you, Chairman. I just want to share that I used to have a full coverage by Kaiser Permanente, but I changed my job, and right now I'm a part-time job in the community, searching for DACA people. So now, under this new job, I had to face that I have to find a new plan for my health. So fortunately, I can do it by ACA. I have medical, so now I have a good, I have happy face on me. So for me, it's very important to have a coverage, because if not, I'm not able to have a money if something happens to my health. If it gets an accident or if it is a chronic disease. I have a history of my family that is cancer and high pressure. So I'm very concerned of my health now, and I need to be screening my health frequently after I know that. My dad passed away almost 1 year ago, so that made me that umbrella that I need to be more concerned about it. So I just want to share this with all of you. Also have a physical disability that is for being like around 10 years, and I am not stopping to work. I don't want to stop working. I want to work. I want to be succeed, and also I think after death I want to be succeed. I want to be productive. So many issues that we face in this moment. I guess I'm not the only one that facing many situations. Health. I want you to be ahead, to be with ACA and get it better for our community. As I guess we are here together because we have a dream, but in this dream is that we can all have a health care. Thank you very much.
Thank you very much. We will now open up to public comment. You can come forward, state your name. If you have a organization you represent, if you can do that as well, and just make a brief comment. Thank you very much.
Mr. Chairman, members of the Senate, Dr. Arambula, thank you for this opportunity. My name is Victor Christie. I am with California Health Plus Advocates. We are the advocacy arm of the California Primary Care Association. Community health centers are a local, innovative, cost-effective, and bipartisan solution that ensures access to excellent health care for everyone. And I know I'm preaching to the choir, but California's most vulnerable and underserved communities have the most to lose if health care coverage programs are rolled back or eliminated. I just want to add that if the repeal is to occur, we want the replacement to include three things: access to care, workforce, and coverage affordability. And one final note, Dr. Arambula, I wanted to share this fact with you and the rest of the committee in regards to an economic figure. In California, community health centers have an $8 billion economic impact, supporting 58,000 direct and indirect jobs and contributing $1 billion in tax revenue. Thank you all so much, and we look forward to working together.
Thank you. Good afternoon.
Good afternoon. My name is Bernice Bonillas, and I'm with the local chapter of the California Alliance for Retired Americans. It's a nationwide organization. I know there's a good one in Fresno, Senator Arambula. Anyway, I hate to speak after all these fabulous speakers we've had today. That Steve Schilling is something else, isn't he? Yeah. Well, you know, he actually ran.
I don't know about Steve Schilling.
He actually ran for the assembly at one time, many, many years ago, and he lost. But if he'd have won, I bet he'd be president probably. But anyway, if D.C. legislatures accomplish their goal of doing away with the Affordable Care Act, what do we have as a backup? Anything here in California? Because I don't know about the feds when we're ever going to be able to get something, you know, to replace that. But anyway, remember Sheila Q? Was it Senate Bill 840? Was that the number? Does anybody? 810. 810?
Single payer?
Single payer.
810.
Okay. Well, you know that several analyses were done on that bill, and it proved to be very, very affordable. And the analysis even included undocumented workers. It was based on residency of California. You know, if you're here 6 months, you would be able to purchase the plan, the premium. But I don't remember anything negative about that. It actually passed the Assembly twice, the Senate twice, and we thought we had it, but as you know, we had the other party governor, and he didn't sign it, so we lost it. And is that in anybody's bills presently in the Senate or the Assembly now? Maybe getting that back and starting, a backup that we can like have ready to go in case this thing goes? That's my question.
I second that question.
Don't know of any members that are introducing it.
How about Dr. Hernandez?
Right now, I'm more interested in making sure that we have what we have right now to be successful, that we implement it, but more importantly, we protect it.
Okay. Well, that's something we're still going to be looking at because we need it. Thank you.
Thank you. State your name and where are you from, please?
Good afternoon. My name is Pat Nolan, and I'm concerned that every citizen has health care. And I want to thank the California Senate Health Committee for you coming to Bakersfield to hear our concerns. Our U.S. Representative, Kevin McCarthy, locked his office doors in November when over 100 of us went to tell him how much we need ACA. Access to health care. That word access seems to have different meanings to different people. I think everyone in this room has access to buy a Rolls Royce, but I don't think many of us can afford to buy it. People are talking about access to health care that is not affordable, health care that they won't be able to eat or pay rent and afford insurance as well. Without health insurance, people get sick, as we've heard. People die. People need to monitor their health. You can't get blood pressure tests, you can't get diabetes tests, you can't get cholesterol tests. And so what they do is they end up having to wait until they have a health crisis. And then they go to the emergency room. And that is the most expensive care for all of us. We can't go back to that. If the AFA care is appealed, is there going to be a replacement the next day? Any sensible person knows you can't be one day without insurance, because sure as it always happens, that's the day you get hit by a car. We cannot have any lapse in our health insurance. Also, 17 years ago, I had breast cancer. So I have a pre-existing condition, and I cannot get insurance. So it is only through ACA that all of us can really stay healthy and well. So thank you for your time.
Thank you. Anyone else? Public comment?
Hi, my name is Jeanette Limones, and I was born and raised here in Bakersfield, California. Just a real quick background. I come from a single parent home. My mother had 5 children. My dad was around but not around. And I grew up, of course, as a result, I did struggle with a lot of mental health issues and things like that. I got pregnant, had 2 kids. I went to college. I used all the resources that were available to me to get my degree and go to college. So when I think, the Medi-Cal, the government, a lot of the resources I got were really benefited me, and I used them to get my degree. I got a degree in biochemistry with a minor in biology, an honors award recipient, did 3 years undergrad research. I loved it. I felt very hopeful, optimistic when I went to look for a job. I looked for a job. I worked for a little bit, I commuted, finally started working in Bakersfield, close to home. February 1st came my son's birthday. It was about a week and a half before my son's birthday. He was going to be 10. February 13th is his birthday. February 1st, he woke up and, started hearing voices, and it was very hard for me, very frightening. They were commanding voices, threatening him to harm himself, and it was continuous for weeks. And finally, of course, I used my resources, got my son all the help he could get. He's better. I've had, the second half has been better for me. But Tony Aidan from the committee really spoke to me. A lot of the speakers spoke to me today because, of course, they've all spoke to me. Everything that the members have talked about also spoke to me. Because I can relate, I feel like I have I could be a different lens to explain my gratitude and toward, Obamacare. And I learned a lot of things that were new to me today during that I also benefited from. That shows more, I feel more appreciation for, but also feel more fear that we would lose it. I'm proud to be here in Kern County. I love it just like you did, and a lot of people don't, but I do, and I would rather fight for it than leave. But when Tony spoke today, I'm sorry, I forgot his title, but I feel different now. After the way he spoke, I feel like if zip code, and my son, has these, he's diagnosed, he has severe anxiety, unspecified, psychotic disorders, these things, and then, and we also have, other health issues, I feel like it's not just zip code for us, it's also genetic. And then what about when there's a combination of zip code and genetics? Because my father was schizophrenic. And I have a handful. I graduated, felt optimistic. But now, this year, since February 1st and the whole election year, I feel, very oppressed. I feel offended. All year long, I felt offended time and time again. And I would like, I feel, very oppressed. I feel offended. I feel frightened, traumatized. I feel a whole bunch of things. I work really hard, to work and provide for my kids, and move forward. That's why I went to college, because I wanted a better life. And I just want to thank you guys for fighting for the Affordable Care Act, because I cannot go one day without my Medi-Cal and my benefits. Because every day with my 2 children, I don't know what's going to happen. Things just come. February 1st, I didn't know what's going to happen. And thankfully, I had the help, and he's better. And of course, he's doing really well. He's a very good, smart kid. And I don't want him to be a statistic, that Tony talked about with just being in the zip code in a rural area. I would rather move now, even though I am proud to be here. But if I can put him somewhere where he will be happier and live a better life, then I will move for my son. And I just want to thank you guys for your time, and everybody here. I learned a lot today.
Thank you. Appreciate
Thank you.
your comments. Anyone else? Any other public comment? Welcome. State your name.
Good evening. My name is Pedro Elias. I'm the Director of Public Affairs for Planned Parenthood, Marmonte, which covers, I'm responsible for 8 counties here, from Kern to Stanislaus counties. And I see my assemblymen here, and thank you for being here. I'm here to talk to you all about my connection to Bakersfield and the importance of, I adopted 2 twins, a boy and a girl, from Kern County, from Bakersfield, that my wife and I adopted in 2011. They were 9 months old when they came home. And so Bakersfield has a special, connection to me and to my heart. But being here, making, this hearing available for all of us who live nearby. I live in Fresno, but it's important because, again, you hear these stories, you hear these testimonies, and knowing that there's folks that will suffer. There's folks that have had a positive impact because of this. Many folks, and I want to say that as a parent, it makes a significant difference because I've seen young people in our health centers. We offer primary care in some of our health centers, as many of you know, and specifically here in Bakersfield, we offer reproductive health services. We've been here nearly 30 years, and those are the services we've offered for nearly 30 years. And many folks, many residents in this area aren't aware of that. And when it comes to the repeal of ACA and including Planned Parenthood in that repeal and defunding Planned Parenthood, in calendar year 2016, we had over 14,000 patient visits at Planned Parenthood. And I know I got my good friend again, Steve Schilling. I was calling him a pitcher, Kurt Schilling. Steve Schilling, good friend of ours, again, who's also stood by us in the long run, and I appreciate that because we work together when it comes to family planning services. We do good work here. We continue to do good work here, and that's why we're still here. So I want to just say thank you to all of you, and knowing that I do have 2 girls, my 2 daughters, I want to make sure that ACA is still here even then, because I don't know what road they're going to take. I'm going to do my best as a father to be there for them, but I also want to know that there is a place for them to fall back on if there's a need. So thank you so much, and women power.
Thank you. Anyone else? Public comment.
Hi,
I'm Caitlin Tierce, and thanks for listening to me. I'll try not to cry. I had I was diagnosed with epilepsy in 2010. At that point, I was 25, and I couldn't get insurance with my parents, so I had no help. Didn't matter that I was from a privileged white family that could afford it, because no doctor would see me without insurance. And it was really difficult, and my mom fought so hard for me. And luckily we were able to find somebody that would see me, but even then the medication was too expensive. Finally, the ACA was available, and honestly, it saved my life. And I know that it saved millions of other people's lives, and jobs too. I mean, it's so important that we have it, and it makes me really upset that there are Republicans and other people that want to repeal it when, you know, if you have sick people, they can't work. You want them to work, you want them to pay their way. That's what you don't like poor people, then you know what? We got to take care of them, right? So if they're not healthy, then they're not going to be able to pay their taxes and do everything that you want them to do. So I think it's really important that we keep the ACA available to everybody. We need to be on a single-payer healthcare system, but I'm okay with what it is right now, and I am more than willing to pay taxes every year of my life to make sure that everybody else can have that same privilege, because we deserve it. We all do. I mean, we shouldn't have to be scared that, like, I'm gonna wake up and not have insurance. I'm not gonna have medication. I'm trying to stock up on medication in fear that I am not gonna be able to have it. And it scares me to death. I have a son that I have to take care of. What's gonna happen to him if I'm not around? Will he go into the system? And what are the Republicans gonna say then? You know, they don't want that. So they need to understand that without us being healthy and being able to take care of ourselves, we will never accomplish anything. So I really hope that it doesn't get repealed, and thank you for listening. And
Thank you, ma'am.
Good afternoon, Richard King, actually from Los Angeles. President Pro Tem De Leon is my representative, as well as Assemblymember Friedman. I want to say, just to piggyback on what was said earlier about Senate Bill 810, that's a single-payer program that was put forth by the state Senate in 2009 and 2010. It passed the floor both years. The governor vetoed it, and then it was not passed in 2011. I think that we're dealing with an opposition party in D.C. that is always screaming states' rights. I feel like we should scream states' rights back, and we should allow our Californians to have single-payer health care, and we should just not worry about what's going to happen with the Affordable Care Act, because you have constituents here in this state that are affected regardless of what's going to happen. The Republicans have tried to repeal the Affordable Care Act 60 times, and now they're finally going to be able to do it. And so you guys have the power to do something about your constituents locally here, and we can provide them with health care locally within the state, and we don't have to worry about what's going to happen in D.C. And I feel like that's a responsibility that you guys have as members of the Health Committee to try to pass either 810 or something similar to 810. If you're worried about how to afford it, there was also a bill that was passed, ARJ 43, that was asking D.C. to enact a carbon tax, right? All right, we'll enact a carbon tax here. If you sell goods in California, well, then you have to pay a carbon tax for your carbon footprint. And then you can take that money, you can roll it into healthcare. There's got to be a way to pay for it within the state. And I just think it's ridiculous that we as Californians who lead the nation in progressive politics cannot have a single payer system statewide. 6th largest economy in the world, largest state population, 40 million people here. There's going to be a lot of people that are going to be affected by the repeal of the Affordable Care Act, which is going to happen. It's inevitable. So let's not cry about it going away. Let's figure out how we can keep our people healthy and safe here within our state. Thank you.
Thank you.
Anyone else? Dr. Mitchell. Dr. Mitchell. Dr. Mitchell is Cal State President. Senator Mitchell. Anyway, we're having a big Day of Action rally at Kevin McCarthy's office on the 27th, tomorrow at 2 o'clock, and we got them coming on buses statewide.
Hello.
Okay?
I would appreciate if we not do any political
Oh, no, this
statements
is just
here.
because she mentioned it.
No.
That's why I thought.
Thank you. Anyone else? Public comment, if we can be germane to the issue at hand. This gentleman, if he can be after you, because he's been trying to come up for a while, if you don't
okay.
mind, we'll let you go first, and then let this gentleman go next. But if we can try to be germane to the issue at hand, this is the Affordable Care Act, access to care, affordable care, and no public statements, please. Thank you.
Good afternoon. I'm Mary Adair with the County Behavioral Health Directors Association. We represent local county behavioral health departments providing mental health and substance use disorder services to hundreds of thousands and at times millions of Californians. If the Affordable Care Act is repealed without a comprehensive replacement, millions of Californians will lose access to important behavioral health services. One of the main mechanisms by which this may happen is through the essential health benefits, 10 categories of services that must be provided in health benefits, 2 of which are mental health and substance use disorder services. Today, Medi-Cal enrollees with serious and disabling mental illness are eligible for county county specialty mental health services. If the Affordable Care Act expansion is repealed, single, low-income, childless adults with serious mental illness that just recently got coverage through Medi-Cal will lose eligibility for these services.
Thank you.
Good afternoon, Mr. Chairman. My name is Fernando Miranda. I was born in Bakersfield and raised in Lamont. Thank you for the opportunity to share my story. In 2003, when I was 13 years old, I went to my doctor for an earache. It was that same visit my doctor diagnosed me with asthma. Fast forward to September 2007, as a college freshman at CSU Bakersfield, I felt ill, but I did not worry because I knew that the Student Health Center would cover me because it was covered in my tuition. And on the side note, my sister had cancer, and my brother on and off went to the Student Health Center and saw part of her treatment there at the Student Health Center. Going forward, fast forward to January 2014, as I wondered what I was going to do after graduation, it was that same health center where I signed up through for insurance through Cover California. Since graduation, I have worked a few temp jobs, but haven't found anything permanent and have decided I want to go to grad school. However, a few days ago, I helped my dad remove his old bed cushion. Just yesterday, I got a sharp pain in my abdominal area as if broken glass was tearing the underside of my skin, but has now gone away. I fear that it might be a hernia. I asked myself, now the day before the president-elect takes the oath of office, I asked myself whether or not I should go to the doctor's office and I found myself here before you speaking on behalf of the ACA, which has become nothing short of a lifeline for thousands, if not millions. As of this moment, I owe over $39,000 in student loans. If I lose the ACA, I will be one severe sickness away from being even more in debt. My parents are currently processing their Medicare Medicaid benefits. My mom has type 2 diabetes and takes about 5 medications, in addition to an ongoing eye condition. As of right now, she will be able to afford her medications, and it frightens me when the Speaker of the House wants to turn the Medicaid program into a voucher system, from what I've understood. My parents are in their golden years. They should not have to worry about this. And last but not least, I'd like to thank you for taking your time to coming to Bakersfield.
Thank you.
And I have just a question. What's the name of the study that I think Steve Schilling read from?
UC Labor Center.
Okay. Do you have the title of the article?
What we can do is our staff can get it for you before you leave. And
Okay.
Is Mr. Schilling still here or not? I'm not sure if he is or not. No, he's left. Okay, we will get the information to you.
Okay, thank you.
All right, thank you. Any else? Public comment? Name and where you're from, please.
My name is Lydia Rivera, and I'm from Kern County. Are you guys tired this evening? I am.
I'm not tired.
I'm very tired. I just went to work. I've been working for the last 33 years. I've raised a son by myself. He's now a correctional officer for the state of California. I'm not asking for a handout. I'm just asking for a hand. I have my 2 knees reconstructed, and I still get up every morning, go to work on time, go to work every day out of the year, and I need the Covered California. I take medication to help me with the pain so I can get up and be productive and go to work and do what I have to do to survive. Because I'm on my own. I work, I take care of myself. There's nobody there. I don't have a husband. My son is on his own. He's married. He's taking care of himself, and I got to take care of myself. And with this Covered California, it's helping me. That's all I need. That's all I wanted to say. Thank you. Good evening.
Thank you, ma'am. Next person.
Hi, my name is Edgar Aguilar. Kern County has been my home for the last 10 years, but I grew up in the Salinas Valley. My father worked the fields of the Salinas Valley for over 30 years. He worked for small and large agricultural companies, but never had health insurance. I believe access to health care is a right, but for my family growing up, it was a luxury that we could not afford. About 3 years ago, I helped my parents with a Covered California application. They qualified for subsidies, and he was able to see the doctor. He went to the doctor, and he was diagnosed with high blood pressure and diabetes. And then he told me, see, that's why I don't want to go to the doctor, because they're going to find something. Fortunately, he's been able to control his illness through medication that he can afford thanks to the Affordable Care Act. My grandfather died due to diabetes complications. My grandmother died due to diabetes complications. I don't want my father to die because he doesn't have health insurance. Through my work, I'm able to meet hardworking people just like my dad on a regular basis. People that would not be here if the Affordable Care Act had not provided them access to the health care that they need. And thank you for being here and fighting for our health care. It's a right that we all should have, but unfortunately, they want to take it away from us. So thank you.
Thank you. Anyone else? Public comment?
Hi, good evening, Mr. Chair and members. I'm Tam Ma with Health Access California, the state healthcare consumer advocacy coalition working for quality, affordable health care for all Californians. I first want to start by addressing a question that Senator Newman raised earlier about the impact of a proposal that would allow insurers to sell across state lines and what that might mean for California consumers. Essentially what that proposal would do is preempt California's very strong consumer protection laws that date back date back decades into the 1970s. And so some of those consumer protections include requirements that health plans and insurers remain financially solvent, requirements that they provide medically necessary care, that's like doctors, hospitals, lab services, maternity care, and reproductive services, making sure that health insurance companies have adequate networks, enough doctors and hospitals in their networks so that consumers can access them. We have strong protections through the independent medical review program. So if a health plan denies somebody care, a consumer can appeal to the state and have an independent panel of doctors look at their situation and decide whether they should receive that care or not. And in most circumstances, the panel will order the health insurance company to provide that care. We have strong protections around non-discrimination, language access, and whatnot. Surprise medical bills that this legislature worked so hard on last year, accurate provider directories, all of those consumer protections that are provided in California law could be gutted if insurance companies are allowed to sell across state lines. And so you've all heard today about what the Affordable Care Act means to consumers. It's not a political prop. It's a matter of life and death to consumers. And I just wanted to highlight some key statistics. Since we're in the southern San Joaquin Valley today, in terms of the number of people who've benefited through Medi-Cal expansion and Covered California in Congressmember Valadeo's district, that's 111,000 people. In Congressman Nunes's office, 86,000 people. In Majority Leader McCarthy's office district, 82,000 people. And as Mr. Arambula stated earlier tonight, ACA repeal is detrimental to California's economy, and it does cost the San Joaquin Valley more jobs than that was lost to the drought in 2015. In Kern County, we would be losing 5,000 jobs, and that's 3 times more than if Chevron laid off all of its employees in this county. And Tulare County would be losing 3,000 jobs. 2 of the top 10 employers in Kern County are hospitals. And Mr. Rambula, in your district, 3 hospitals are among the top 10 employers in your district, or I'm sorry, in your county. And that in Fresno, there would be 6,000 jobs lost, and that would be more than 5 times the impact if Foster Farms were to lay off all 1,100 of their employees in Fresno County. And and going to the state budget, we would be losing $22 billion in federal funds, and as you all know, that's money that the state cannot backfill. And $22 billion is more than the state of California spends on higher education. And I think, my last important point here is that the ACA was signed into law in March of 2010. People were not enrolling into coverage until January of 2014. And that's because it took nearly 4 years to set up the systems and the programs and everything so that people can start enrolling and benefiting from the coverage. And for the members who've served here for a while and for those that are new, you know that it's very hard to transition people between programs. These programs are complicated. There's always glitches and issues to work out. The ACA, had a tremendous impact on people's lives. It's not perfect. There's always things to continue improving upon. But repealing the Affordable Care Act without a replacement in place just creates so much chaos for the health system, for the hospitals that you've heard from today, for clinics, and for all the consumers who've come today and talked about how much they rely on their health coverage to stay alive. And it's awful that people are trying to stock up on medications now in case they lose their coverage. It's awful that people are worried about losing their limbs if they lose the coverage. So I think our message really to you all and also to the folks in Congress who are looking at proposals is, really we should be focusing on improving the programs that we have, making them better, and not pulling coverage and care out from under people because it, is bad for our economy, it's bad for people's health. So thank you very much.
Thank you. Good evening.
Good evening. My name is Julie Solis, and I live here in Bakersfield, California. I've lived here for 21 years. I came this evening to speak with you and show my appreciation that you guys all took time to be here. We all appreciate it. My story is of my husband. In the late 2007, in December, my husband started getting a little bit ill. We thought it was the flu. And when the new year came, I started bringing him to the doctor in January. He continually got sick, and this was before the Affordable Care Act. This was when it was very expensive and pricey to go. So by springtime, we had cashed in my oldest son's college $10,000 CD to help pay for medication, and he's now a senior, graduating with no college. His money was spent on medication. My husband did not get better. He kept getting worse. And his work had to start laying him off because he wasn't able to go to work. And so then COBRA was going to be $2,000 a month. And we couldn't afford $2,000 a month. So we just signed my husband up for $900. And that was just for the COBRA. That still wasn't co-pays. And so we used our second daughter. We cashed her CD in to use that to help us. And then we used our third daughter's. And then we sold our home. And then we sold our van. And we've now sold everything. I even sold my wedding ring to pay for his medicine. He takes voracizole because my husband has valley fever, known as it's coccidiosis, and it's an orphan disease here in Kern County, and it travels all over the state. And my husband did nothing to do it. It's not preventable. It's a spore in the air, and now our family has been punished. My son, graduating, has nothing to help him to go to college other than me selling baked goods and making t-shirts and things like that to help make ends meet. So when my husband was ill and we got COBRA, we didn't have a choice because pre-existing condition was there. And what do you do when I started going to all these companies and my husband's dying and they're saying, we can't take you. We can cover you and your children, but we can't help him. His medication, Vorkazoli, costs $16,000 a month. That's $16,000 a month to keep him alive. And I'd gladly pay, and I wouldn't complain. If I had the money, I would gladly pay. We just don't have the funds to pay. It's not that we want the Affordable Care Act so that we could freeload off the rich people, so that we could just live luxury and not have bills, not pay medical. The Affordable Care Act is not for that. It's to keep us healthy. It's to ensure that we're healthy so that we could be productive. Because without health, we cannot be productive. My husband was a very productive person. He was a strong man before his illness. We volunteered throughout the community. Police Activity League, we volunteered. American Youth Soccer Organization, my husband has coached in more places than I have fingers. And then whenever it came time that he needed help, it seemed like everybody turned around and just kind of didn't help. And so then now, during this whole election time, I started being proactive, because if this gets overturned, I don't know how we're going to get medication for my husband. And that keeps me up at night, wondering what's going to happen and how will he live, because the bills keep him alive. So I just ask that you continue to do what you can to ensure the safety of our community, because with valley fever, it's not preventable. If you breathe, you're susceptible. And I hope that when you guys go back home to your parts of the state in 10 days, if you start feeling a little ill, please get tested. We're in an epidemic here right now. Thank you for your time. May I come up and leave you guys with a poster to take back with you? It's information about valley fever.
We'll leave it with the sergeant. Thank you very much.
Thank you for your time.
Thank you. Anyone else public comment? Okay, seeing no other public comment, I'd like to just make a couple closing remarks. First of all, let me thank the Supervisor Perez, for allowing us to be here and opening up this venue. She's been an incredible friend, but more importantly, she's been here the entire time, just intently listening. Second, let me thank all of my colleagues who drove from Sacramento here to Bakersfield to be here. And why did I choose this area? Well, I chose this area because this will have some of the greatest impacts on healthcare and healthcare outcomes if we repeal the Affordable Care Act. This is something I believe in truly and strongly. And if you look at what California has done, California has been an incredible leader in the implementation. The first to have an exchange which is an active purchaser that has been holding down cost. Yes, they've been going up, but they have been holding them down. One of the first states to do Medicaid expansion, and we now are covering 1/3 of the population. I've been honored to carry and implement all the federal act bills, which include all of the patient protections, everything you've heard about, the 10 essential health benefits. Look at, we now have individuals that have maximum out-of-pocket expenses that won't go into bankruptcy because of a health condition, like these compelling stories we heard. It's kind of, it's interesting and sad that I've heard comments as terrified, scary, crumbling inside, stories of people who've lost their life savings to try to make sure they have access to health care. And I think it's incumbent upon us to make sure that we continue to voice our concerns. Yes, we have a new administration. The new administration wants to repeal it. They say they want to replace. What I am saying is we need to be part of that conversation. I want to be part of that conversation. I did not come here to be disrespectful to anybody, and I am going to reach out to anybody who is willing to have that conversation with the California State Legislature to make sure that whatever comes out with a system that will benefit everybody. But I think in closing, we need to make sure whatever system we have, that we have mechanisms in place to control healthcare cost. There have been numerous individuals and entities and within the federal law that have that, and there's things that we need to look at. For example, rising prescription drug costs are skyrocketing in this country and in this state, and we have to have that conversation not only at a national level, but at the state level. And at the end of the day, we have to make sure that every single consumer has access to health care that's affordable, because I believe it's a right for all the citizens in this state and in this country. So I just want to close by thanking everyone, thanking the Central Valley, and thanking Bakersfield for allowing, and Assemblymember Arambula for allowing us to be here. And with that, members, the meeting is adjourned.